Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today's episode, we will be bringing together 4 of the most important and high stakes complications of cirrhosis that every bedside clinician caring for acutely ill patients need to recognize and know how to manage. And those are esophageal variceal bleeding, spontaneous bacterial peritonitis, hepatorenal syndrome, and hepatic encephalopathy. We will begin by diving into variceal bleeding, reviewing the resuscitation, medical therapies, management strategies, key bedside priorities. Next, we'll discuss spontaneous bacterial peritonitis, SBP, when to suspect it, how to diagnose it, evidence-based treatment approaches. We'll follow that by hepatorenal syndrome, focusing on the underlying pathophysiology, connecting that to diagnosis and management. And lastly, we will finish with hepatic encephalopathy, where we will review why it develops, how to identify precipitating factors, and the principles of management. Together, these 4 conditions account for many of the most common and life-threatening reasons patients with decompensated cirrhosis present to the emergency department and get admitted to the ICU. By the end of the episode, we hope you will have an excellent framework for recognizing and managing each of them at the bedside. If you enjoy this type of in-depth, physiology-focused, emergency critical care educational content, and you want to continue building your knowledge base, consider joining more than 1,000 of like-minded folks in our Whiteboard Medicine Patreon community. Members receive access to a complete library, a complete curriculum, including study guides, one-pagers, practice questions, mini courses, clinical reviews, ad-free videos, and every other day medical education posts on all things emergency critical care. Your support also helps us continue producing a lot of this educational content online. So if you have an interest, check it out, linked in the episode description as well as the pinned comment on YouTube. No further ado though, let's dive in. Today's topic is one that comes up not infrequently in emergency critical care medicine, and it's one that can be incredibly deadly, and that is esophageal variceal bleeding. Specifically for the purpose of this episode, kind of that unstable or massive esophageal variceal bleeding. So that's what we're going to dive into today. We're going to start by talking about the pathophysiology of portal hypertension in general, how it contributes to esophageal variceal bleeding. We'll talk about recognizing the clinical presentation, how to initially stabilize these patients, some evidence-based pharmacotherapies prior to endoscopy, some of the therapeutic options, including endoscopic band ligation, balloon tamponade, and tips, and then some pitfalls to management of these variceal bleeds, and we'll end with a couple practice questions to see if we have learned anything together. So no further ado, let's dive in. As a friendly reminder, always, this is just intended to be medical education. This is not intended to be acted upon as medical advice in any way. It should not replace local protocol, specialists, guidelines, blah, blah, blah. So all just educational content here. Let's start with why variceal bleeding matters. Why are we even talking about it today? Well, esophageal variceal bleeding in general is one of the most dangerous complications of portal hypertension and cirrhosis, right? So in cirrhosis, we can develop portal hypertension. That is because the liver, I don't know why we just decided we were going to try to draw a liver, gets cirrhotic, right? It gets fibrosed. So the blood trying to travel into the liver has more trouble traveling through that fibrotic liver, which increases the intravascular pressures. That's portal hypertension, hypertension in the portal vascular system. And that can lead to a couple of dangerous sequelae, one of the biggest ones being esophageal varices. All right, unlike many non-variceal upper GI bleeds, right? GI bleeds from not varices. Variceal hemorrhage can result in an incredible amount of blood loss, right? This can lead to hemorrhagic shock, airway compromise, multi-organ failure, and all these things can contribute to death. This is a very, very deadly complication of portal hypertension, these variceal bleeds, and it can be incredibly hard to manage, right? And we'll get into that a little bit as we go through. So luckily, over time, the mortality has significantly improved, given advances mostly in kind of vasoactive medications, antibiotics, endoscopic therapies, tips, etc. But this is a real emergency. This is the real deal. This is a difficult thing to manage. Less difficult to identify, but certainly difficult to manage. And as a friendly reminder, we should say all of our study guides, what we are going through in this episode, all these are available on our Patreon community. You can download them, annotate them, take them with you, do what have you. So this exact guide that we're going through in this episode is available on our Patreon community. And, we're really excited about this Patreon community. We've been putting a ton of time in, and we've been so grateful and lucky that it's gotten a lot of traction. I think we have over 1,000 subscribers on there now, and there's study guides, practice questions, medical education, post mini courses, kind of whole comprehensive ICU curriculums, all that on the Patreon page. So we'd love for you to consider joining our Patreon community. If you're interested, it is linked in the episode description as well as the pinned comment on YouTube. So don't be shy, check it out. There's some free trial stuff going on too, and I think this will give you access to a lot of the content to check out if you like it before you kind of join a full membership. So, okay, back to the... All right, so pathophysiology of esophageal varices all ties back to what we've kind of already hinted at, and that is portal hypertension. This drives the formation of these varices, both esophageal, right, in our esophagus, which is what we probably think of most often, but you can also get gastric varices, varices in the stomach. You can get rectal varices, obviously varices in the rectum. So esophageal varices we talk about most often, but this portal hypertension can lead to varices in a bunch of different places. And what's actually happening here is as portal pressure rises, right, that pressure in the portal vascular system, blood has to be diverted through collateral pathways, right? These pathways bypass the liver because that liver is fibrotic. So blood flow that usually would be traveling through the portal system into that liver is all fibrotic. So what happens is we get higher, we didn't spell fibrotic right, but ignore that, higher portal pressures here, and that leads to all these collaterals developing in different places to try to bypass that fibrotic liver. And one of the major collateral pathways is the distal esophagus, right? These create these really thin-walled venous structures in the esophagus itself, and that is what we call esophageal varices. And as one can imagine, talking about thin-walled venous structures in the esophagus, it's not surprising that these things bleed like stink when they start to open up. So as portal pressures continue to increase, the varices get bigger, wall tension increases, and risk of rupture rises. And this rupture is what can lead to these massive esophageal variceal bleeds, which you sometimes abbreviate EV. So a useful concept in thinking about this is that this is fundamentally a portal pressure problem, right? This explains why the therapies we sometimes do, at least chronically in the outpatient world, are therapies meant to reduce portal pressures, and that is what can improve outcomes. But this is a portal pressure problem. This is a problem that is birthed because those portal pressures are high, creating those collateral veins that travel through these different structures like the esophagus, stomach, rectum, etc. All right, let's talk about the clinical presentation here. Well, the clinical presentation is similar to an upper GI bleed, but a really massive, robust upper GI bleed. So you get hematemesis. You can get some melena if it's a slow variceal bleed that travels through the intestine, becomes melanotic, but a brisk upper GI bleed can cause hematochezia. And this is a really important point, right? Those that are newer to this game may not realize this because often when we think upper GI bleeds, which an esophageal variceal bleed is, right? It's from the esophagus. We think hematemesis, right? Bloody vomit. And then we think melena if it comes out of the rectum, because that's to travel through the whole intestine, and as it travels through the intestine, all that hemoglobin gets digested and it turns dark into melena. But when these upper GI bleeds are really robust, they're really fast, they're dangerous, it can actually lead to hematochezia. And hematochezia, as a reminder, is bright red blood coming out of the rectum rather than dark blood like melena. And when you see hematochezia from an upper GI bleed, that is a oh boy moment, because that means that blood is traveling so fast through the intestinal tract that it doesn't have time to turn dark like melena. And that implies that this is a really brisk upper GI bleed, very dangerous. And then obviously the symptomatology that can follow are things like syncope or loss of consciousness, right? We're bleeding so much that our intravascular volume is so depleted that when we stand up, we get lightheaded and we syncopize. Hypotension or low blood pressure, shock, obviously hemorrhagic shock can result from this. So these are all things to look for, which are probably somewhat straightforward. Some of the historical clues here, right? When we see an upper GI bleed in a patient with known cirrhosis or portal hypertension, we really should just assume that it's an esophageal variceal bleed. Because at worst, you assume wrong, and you're still kind of managing aggressively. And a lot of the management for a variceal bleed, which we'll get into, overlaps a little bit at least with just an upper GI bleed from a non-esophageal variceal source. So if a patient has cirrhosis or portal hypertension, they're having an upper GI bleed, the safest thing is probably just to assume that it's a variceal bleed and treat as such. And if it turns out not being, well, that's probably a good thing in general. The other things to look for historical clue-wise are maybe they don't have a known history of cirrhosis, but they have some sequelae of cirrhosis or portal hypertension. Things like ascites or some of those stigmata of cirrhosis, spider angiomata, Oh boy, now we're totally forgetting the other stigmata. People can let us know in the comments, and that'll be something that we could revisit after this episode. But let's just put stigmata of cirrhosis. Even if they don't have known cirrhosis, these stigmata can be a hint that the patient has undiagnosed cirrhosis. And then any kind of disease process that can lead to cirrhosis, alcohol use, hepatitis, and then certainly prior variceal bleeding would be kind of a slam dunk clue there. On the physical exam, oh, we forgot that we put it on here because we knew that we would forget. This is a lot of stigmata of portal hypertension or cirrhosis, and it's things like ascites, right, fluid in the belly, jaundice or yellowing of the skin, splenomegaly or enlargement of the spleen, spider angiomas, hepatic encephalopathy, all these things that suggest the patient has portal hypertension or decompensated cirrhosis, all should then make you think immediately, is this a variceal bleed rather than the other kind of batch of upper GI bleeds. All right, initial stabilization of these patients, really ABCs, right? Like much of acute resuscitation is a nice start. It's a little more complex than this, which we'll get into. So there's certainly nuance and caveats here, but it's a decent way to start. So A being airway, right? Massive hematemesis from something like a variceal bleed creates a substantial aspiration risk. And many of these patients need to be intubated, right? They're so altered, they got large volume hematemesis, they can't protect their airway, etc. But you got to be very careful because the intubation itself causes hemodynamic changes, and this can precipitate cardiovascular collapse and hemorrhagic shock. So you really should aggressively resuscitate these patients before or while taking their airway. So it's all about like, what is the risk stratification? So do I have time to resuscitate this patient before I take their airway? You know, maybe they're really altered, but they're not actively aspirating. And you're like, oh, they're going to have to go for EGD. I'm going to have to intubate them and take their airway, but I have a minute, then you should aggressively resuscitate them. But if it's an emergent airway and it's got to be done right now, at least resuscitate them in tandem, because obviously when you intubate them, part of that is you have to, well, don't have to, but many places do RSI rapid sequence intubation, and that requires us to push hemodynamically effective medications, and which medications you use and what hemodynamic changes those can incite is certainly different, and we could probably do an episode on the physiologically difficult airway if that's of interest, kind of how to approach these airways. But the key fact here is you want to resuscitate them, you want to replace blood volume, you want to get them as hemodynamically neutral as possible before you induce them and intubate them, because putting them on mechanical ventilation also is going to decrease their preload. We have a whole episode on the hemodynamic effects of mechanical ventilation, so you could just search that if you're interested. Whiteboard medicine, hemodynamic effects of mechanical ventilation. But this is a very hemodynamically tumultuous procedure, so you got to be really careful in these patients in hemorrhagic shock, because if you take away their sympathetic surge, their vascular tone, and then put them on positive pressure where that decreases their preload, you can cause hemodynamic collapse. So just like the thing to take away is resuscitate before you intubate if you at all are able to. Okay, circulation stuff. This is somewhat generic advice, but it shouldn't be underappreciated. These patients need 2 large bore IVs and continuous monitoring, right? These patients often need blood transfusion, and we have a whole series of episodes on blood transfusion and cryo and FFP and all that, so check that out if you're interested. But some of these patients need massive transfusion protocol as well, so you need good vascular access. You quite literally, that's one of the smallest things you can do that can have the biggest impact. And good vascular access is in the eye of the beholder a little bit. Most people would say at least 2 18 gauge IVs. Some would say, let's try to get even bigger ones, 16 gauge. Other folks would say, you know, let's put in something like a cordis or a trauma line or a sheath. You can actually transfuse, which we like to do through a trialysis catheter that you place at the bedside. It's kind of longer and less flimsy than a cordis, but all these things are large bore. So you need large bore access. Something like a classic central line, right? A CVC, central venous catheter. You certainly can use this. It actually can't transfuse quite as fast as an 18 or 16 gauge IV, or certainly any of these bigger sheaths, just because flow through these things is going to be based on diameter of the catheter as well as length And if you're familiar with these, a CVC, a kind of classic central line, is long, so the flow through it is actually slower than a shorter thing like an 18 gauge peripheral IV. So just something to note. You can use it, you won't be able to transfuse as fast. All right, and then obviously obtain blood work, CBC. Do note, this is a classic rookie mistake. Someone comes in with an upper GI bleed, they're hemodynamically unstable, you're worried it's a massive GI bleed, but their hemoglobin is normal or it's barely low, and you're like, so because their hemoglobin is normal, it's not a massive GI bleed. Don't fall into that farce. Don't fall into that trap, right? We bleed whole blood. So here's a blood vessel. When we bleed, right, we have a defect in the blood vessel somewhere, and all this blood is leaking out. We bleed whole blood, so the hemoglobin is not going to reflect that right away. You actually need time for all kind of the interstitial stuff to get reabsorbed into the blood vessel, which then will kind of quote unquote dilute out the hemoglobin and show that the hemoglobin is lower. So an acute GI bleed might have a normal or only slightly low hemoglobin, and don't let that fool you, because that hemoglobin needs time before the hemoglobin that you send to the lab will actually appear to be low. All right, make sure you have coags. INR in this case, in someone with cirrhosis, can be misleading, right? People with cirrhosis don't produce some of their coagulation factors, but they also don't produce things like protein C and S, and many of them have a balanced coagulopathy, which I guess wouldn't be a coagulopathy, but the INR is not the best test for it because it does not take into account things like protein C and S. It just looks for if we're missing factors, and people in cirrhosis are missing factors. So viscoelastic testing, again, we've done episodes on this too. Just search whiteboard medicine, TAG, or viscoelastic testing, or ROTEM. So the two most common ones are TAG thromboelastogram and ROTEM, which stands for rotational something. But yeah, TAG and ROTEM are the two most common viscoelastic testing. We won't belabor what that is in this episode. Just check out the episode we have dedicated to that, but these are much better ways to test the actual coagulation cascade than just sending something like an INR. Remember, cirrhotics are often deficient in fibrinogen, so certainly check the fibrinogen if you're not going to do a TAG or ROTEM, because this is something that we commonly will see low in patients with cirrhosis. Excuse us, I had to wet the whistle. Okay, blood product resuscitation, this is important. Bleeding should be replaced by blood. It sounds obvious, but we're always so tempted to give crystalloid, but crystalloid is not what this patient needs, right? Crystalloid will just hemodilute out the hemoglobin, hemodilute out the coagulation factors and cause more coagulopathy, increase the portal pressures because we're filling up the blood vessels, but we're filling it up with fluid, not blood. So bleeding needs blood, right? The resuscitation for these patients is with blood products. And often any type of kind of balanced blood product resuscitation is important. What that means is a much larger discussion, but if you're given a couple units of blood, you should be thinking about if the patient should get FFP and platelets as well, some degree of balanced transfusion. And never forget the calcium. We got whole episodes out on this too. If you're giving more than 2 units of blood, you should consider giving empiric calcium, because the citrate in those packed red blood cells will start to take up all the calcium, and you need calcium for blood clotting and vascular tone and all that kind of stuff. So don't forget to give them calcium. But resuscitate these patients with blood products. If you're given more than a couple units of PRBCs, think about balanced transfusion and giving FFP and platelets as well. And then don't forget, if you're given kind of more than 2-ish units of PRBCs, make sure you give some calcium as well. Do note that, as we said, this is a problem of high portal pressures. So as we fill up the tank, aka resuscitate these patients, it actually will increase their portal pressures, because as we fill up their blood vessels, those portal pressures will go up because that's more volume in the portal system, just like in the rest of the vascular system. So over resuscitation in these patients can worsen bleeding. You got to walk that fine line, kind of a restrictive transfusion strategy, but many of them need to be transfused, but only so much as they need to kind of have better perfusion, right? So look at mental status, look at urine output, look at markers of end organ perfusion, creatinine, lactate, LFTs, all that jazz, and transfuse them to the degree you need to maintain organ perfusion, but don't just go, quote unquote hog wild, because you could over resuscitate them, and that could worsen bleeding by increasing those portal pressures. All right. Oh, we actually wrote this down. Overtransfusion can increase portal pressures and may worsen variceal bleeding. The goal is to restore adequate perfusion, not normalization of the hemoglobin. Nice. All right, let's talk about some medication therapies for variceal bleeding. Obviously, resuscitate these patients with blood. That's most important. But then what can we give them medication-wise to try to help decrease the variceal bleeding? Well, the first thing here, and if you see any doses, again, all this is educational. None of it is intended to be acted upon as medical advice. These doses are just for kind of educational and opinion rather than strict guidance. But the first medication to talk about is Octreotide. So Octreotide reduces portal venous inflow and it reduces portal pressures. And as such, anything that decreases portal pressures is going to decrease the variceal bleeding. All right. So Octreotide is one of the mainstays of therapy. People talk about 50 micrograms bolus with then an infusion, and this should be given for all patients with any suspicion of variceal bleeding. The next one is ceftriaxone, and this is one people sometimes don't think about, and we'll get into the rationale for ceftriaxone, but any patient with cirrhosis and an upper GI bleed is very high risk for a bacterial infection. And when they've studied empiric ceftriaxone, they have found that it reduces infection rate, reduces rebleeding, and improves survival. And this is just because these patients often have concomitant infections, even if we don't notice it, right? Cirrhosis is a immunosuppressive state. And if you have decompensated cirrhosis to the extent that you develop a variceal bleed, you're very high risk for infection. So empiric ceftriaxone is given, typically about 1 gram IV daily. This is not what we sometimes hear people say is this is for SBP, spontaneous bacterial peritonitis prophylaxis. Which would imply if they don't have ascites, that you don't need to give ceftriaxone. That is a falsehood as far as we're aware, unless there's new data that's been out, and maybe someday there will be new data. To be fair, the plot is much thicker. Like if you look at the AAFSLD, if that's the right abbreviation, but the kind of big liver society, who needs empiric ceftriaxone and all that? The plot's very, very thick. The evidence is somewhat variable, but in general, guidelines would suggest you should give ceftriaxone for any upper GI bleed in a patient with cirrhosis, independent of whether they have ascites or not. All right. And then PPIs, this is something we usually do remember because this is what we treat our upper GI bleeds in general with. Variceal bleeding is not acid mediated, but we do commonly still give PPIs just because we don't know the source. So kind of the triple threat here of medications, the cocktail that we should be giving these patients with variceal bleeds is Octreotide to help decrease portal pressures, empiric ceftriaxone to prevent or treat occult infection, and then a PPI. This is kind of the triple threat of therapies for variceal bleeds. But these medications, so we've resuscitated the patient with blood products, we've given them Octreotide, ceftriaxone, and PPI. What the patients often need, though, is endoscopic therapy, right? They need someone to actually go in, one of our gastroenterologists to go in there and try to rid themselves of the varices. So the most common procedure to do this is an endoscopic variceal ligation. We often call it banding the varices. And this is a first-line endoscopic treatment. A small elastic band is literally placed around the bleeding varix, and this then collapses the varix and causes hemostasis. It's highly effective. It's not a lot of complication rates, and reduced bleeding compared to some of the older therapies. So patients should really get this done urgently who have variceal bleeding after they've been adequately resuscitated. Now, if bleeding persists even after they've been resuscitated, they've gotten Octreotide, a PPI, ceftriaxone, they've gotten esophageal variceal banding, what can we do? Well, one thing we can do if the bleeding is severe is something called balloon tamponade. I don't want to speak for anyone out there, but this isn't our favorite procedure. It always seems like it's, a little bit of a challenge, not something that's done too much, but the most common thing you'll probably hear people call this is a Blakemore tube, but there's a couple different kinds. There's the Minnesota tube as well. We're not going to get into this too much, but essentially what you do, I don't think we talked about it in here, did we? No. Essentially what you do, we'll draw out one of them. So it's kind of a rubber hose, and there's a balloon here, and then a rubber hose, and a balloon here, and a rubber hose. And what we're literally doing is we are advancing this into the patient's stomach. So this portion sits in the stomach, and you inflate this balloon, and it kind of compresses the stomach. Then this portion sits in the patient's esophagus. So this is going to be stomach here. If you're listening to this in podcast form, we're doing a very bad drawing, so don't feel like you're missing anything, but we do link all the videos in the description if you wanted to hop over. And then this is the patient's esophagus here. And usually when we inflate the gastric balloon, you'll pull up some upward traction, so this balloon kind of pulls upward into the gastric outlet, and that actually often causes a stop in their bleeding. But if they don't, there's an esophageal balloon here that you can inflate as well to compress those esophageal varices. And again, without providing too much detail, there's a whole bunch of steps in this. You sometimes soak it in ice to make it more rigid. They obviously, shouldn't say obviously, but often need to be intubated. You advance it down, you usually inflate the gastric balloon, check if there's hemostasis, aka persistent bleeding through the esophageal port. If there is, then you can inflate the esophageal balloon, and there's different pressures you inflate it to, and blah, blah, blah. But this is one option. You can do this at the bedside. Many emergency physicians and intensivists are able to do this, although it is a as far as we're aware, no one's favorite procedure. This is temporary though, right? This stays in too long and can cause gastric or esophageal necrosis because you're literally trying to cut off a little bit of blood flow. So this is a temporary bridging therapy. It is not definitive. There are significant complications, and you should, if you're placing this, somebody needs to do something, whether it's GI or IR, to actually try to treat the varices. All right, so this buys you time. A useful phrase is balloon tamponade buys you time. So what else can we do other than balloon tamponade? We're not very familiar with this, but interventional radiology, actually no, GI or IR maybe, can place actually esophageal stents that expand. This can provide temporary control as well. Think of it as kind of that balloon tamponade, but instead of a balloon, it's an esophageal stent. And then the one that people are more familiar with that's probably more common is a TIP. So we're going to come out with a dedicated episode on TIPS. TIPS stands for transjugular intrahepatic portosystemic shunt. And what this does is it creates a low resistance channel between the portal and hepatic systems that then decompresses the portal hypertension. So if we were to draw a very poor picture of a liver, you have your portal system that's trying to go through this fibrosed liver, causing increased portal pressures. But what happens is you'll actually create, we'll draw the hepatic vein here, although it's not. You will create a stent between the portal vein and hepatic vein, so then blood can bypass the liver and travel through the stent into the hepatic vasculature, and this then will decrease these portal pressures because this blood doesn't have to travel through this fibrosed liver anymore. So recurrent bleeding, failure endoscopic therapy, high-risk patients all can consider TIPS. Big potential complications are liver failure, shunt dysfunction, and the hepatic encephalopathy. This is one of the ones that you think most about, right? Because you're bypassing this liver, so there's even going to be less liver filtration of some of those toxins, which can then lead to worsening hepatic encephalopathy. Again, we'll come out with a dedicated episode on TIPS because there's a lot of nuance to discuss there. But TIPS can be life-saving. It's one of the tools in the toolkit for patients who you've resuscitated, you've balanced their coagulation cascade, even Octreotide, PPI, ceftriaxone, you've tried to band, none of this has worked. They're having recurrent bleeding, they're sick. TIPS can sometimes be life-saving in certain patients. All right, we just wanted to shout this out. It's not as much emergency critical care, but secondary prevention. Patients who survive their variceal hemorrhage are at higher risk for recurrence. So the standard secondary prevention is actually non-selective beta blockers, things like carvedilol, propranolol, notalol, because these reduce portal pressures, and obviously reducing portal pressures is going to decompress those esophageal varices and decrease the rebleed risk. There's also, these patients usually get intermittent EGDs and empiric banding and all sorts of stuff. But yeah, not super emergency critical care medicine related. All right, we are almost done here. We have some common pitfalls, some key takeaways, and then some practice questions, and that'll be that. So common pitfalls, trying to wait for endoscopy until kind of these medical management therapies like Octreotide and PPIs kick in. That's not a thing. These patients really need definitive therapy with something like endoscopy, so don't, give it too much time. For getting antibiotics, ceftriaxone does improve outcomes. You should be giving it for cirrhotics with variceal bleeding. Another common pitfall, and this one's challenging, is over-transfusing these patients. If a patient is stable, you don't need to give them MTP, at least not usually, right? Because that will increase their portal pressures and can cause the bleeding to worsen. So, someone who is, almost in cardiac arrest because they're just hemorrhaging to death, obviously you're going to aggressively transfuse that patient to save their life. But those patients that are more stable, you have a little more time, be thoughtful with your transfusion goals. Another common pitfall, which we talked about, was assuming hematochesia, aka bright red blood for rectum, excludes an upper GI source. This can really shoot you in the foot. If someone is sick from GI hemorrhage and they have bright red blood coming out of their rectum, it could be upper. It could be a brisk upper, which is a really bad sign. It could also be a brisk lower, tough to say, but don't let hematochesia in someone sick make you think that it's not an upper GI bleed. Delaying escalation of therapy when endoscopy therapy fails, right? These are really high-risk patients. They're high mortality. So if endoscopy and banding does not work, you should really be thinking about backup modalities like TIPS. Never view balloon tamponade, that Blakemore tube, as a definitive treatment. It just buys you time, right? And then make sure you involve things like GI, ICU, IR early. These are really sick patients. You need a multidisciplinary approach to them, and you need folks that can intervene quickly and pivot on a dime depending on how that patient does and how successful the initial interventions are. All right, some key takeaways before practice questions. Esophageal variceal bleeding is a portal hypertensive emergency. We like that phraseology, which is why we put that in there. Initial priorities are hemorrhage control, resuscitation, and securing the airway. Octreotide and ceftriaxone should be two things that are started right when variceal bleeding is suspected, not confirmed, but suspected. Endoscopic band ligation is first-line definitive treatment. Balloon tamponade is a temporary bridging therapy that you can do at the bedside. And then TIPS is the main major rescue therapy for refractory or recurrent bleeding. Restrictive transfusion strategies are generally favored after stabilization. We've kind of beat this as much as we can, but overtransfusion will increase portal pressures and can make bleeding worse. And then make sure you think about secondary prevention with non-selective beta blockers in patients who survive. All right. Last but not least, some practice questions. See if we learned anything. Those of you who have not done practice questions with us before, the way we'll do it is we'll read the question, read the answer options, then we'll go right into the answer. So if you need more time to think about it, just make sure you pause the episode because we're going to go right into the answer. Question 1. A 58-year-old man with cirrhosis presents with hematemesis and hypotension. Which therapy should be initiated immediately while awaiting endoscopy? A. Colonoscopy preparation. B. An octreotide infusion. C. Lactulose. Or D. Therapeutic paracentesis. Next best treatment option. Pause if you need to. The correct answer is B. Octreotide. Remember, octreotide should be started as soon as variceal bleeding is suspected. It does not have to be confirmed. It should not be delayed for endoscopy. Octreotide decreases your portal pressures and thus can theoretically decrease the amount of variceal bleeding. All right, question 2. A patient continues to bleed despite endoscopic band ligation and octreotide therapy. What's the most appropriate next definitive intervention? A repeat PPI infusion only. B, flexible sigmoidoscopy. C, a TIPS evaluation. Or D, just observe it. Correct answer, pause if you need to, is C, a TIPS evaluation, right? TIPS is the major rescue therapy for refractory variceal hemorrhage and can effectively decompress portal hypertension and save some of these patients' lives. All right, last question. Which intervention has been shown to reduce infections, reduce rebleeding, and improve mortality in cirrhotic patients with acute variceal bleeding? A, routine platelet transfusion. B, ceftriaxone. C, lactulose. Or D, albumin infusion. Correct answer, pause if you need to, is B. Early antibiotic administration is one of the cornerstones of modern variceal bleeding management, and it improves multiple clinically important outcomes. So do it, give it. Doesn't matter if they have ascites or not, give them their ceftriaxone. Today's topic, gosh, we've been doing a lot of decompensated cirrhosis topics lately. If you're interested, definitely check out the page recently. But today's topic is along those same lines. Critical, common, especially for those of us that work with decompensated cirrhotics, and something we should be thinking about really frequently while trying to care for these patients, and that is spontaneous bacterial peritonitis, or SBP. We'll probably call it SBP for the rest of the episode, just to save us a couple words, and that's what we're going to dive into today. Hopefully by the end of this episode you have a great grasp on what SBP is, how to diagnose it, how to treat it, what it can mean for the pathophysiology of decompensated cirrhosis along other lines, HRS, hepatic encephalopathy, all that good stuff. We'll do a little bit on primary versus secondary SBP. We'll go through the actual diagnostic criteria, and then as always we'll end with a couple practice questions. So if this is something that you're interested in, hopefully by the end you'll have a great grasp on it and can teach those around you. No further ado, let's dive in. As always, here's our disclaimer. None of this is intended to be acted upon as medical advice. All of this is just for educational purposes. Please check out the full disclaimer as you see fit here. All right, why does SBP matter? Well, SBP is an infection of the acidic fluid. This acidic fluid is obviously in the peritoneum. It is an infection of the fluid within the peritoneum. You can think about that. It's dark, it's warm, the acidic fluid's got a bunch of nutrients in it. It's kind of a bacteria's paradise. The key here, though, in spontaneous bacterial peritonitis, SBP, is that the infection in this acidic fluid is without a surgically treatable intra-abdominal source. And we'll get into primary versus secondary where that changes a little bit, but kind of classic SBP is spontaneous infection of that acidic fluid without a surgically treatable intra-abdominal source. And in emergency critical care, SBP matters because it's common, unfortunately. And it can be subtle and it can be really dangerous and deadly. A patient with cirrhosis will not necessarily always present with kind of classic peritonitis, right? They may show up just encephalopathic. They may show up with just an acute kidney injury. They may just show up hypotensive, GI bleed, hyponatremic, just not acting right. And it might be SBP that is the cause or the trigger that caused something else to occur. So the big teaching point here, and this is critical stuff. Any hospitalized patient with cirrhosis and ascites deserves to have a low threshold consideration for a diagnostic paracentesis. Some would go as far as saying they all should have a diagnostic paracentesis, but you certainly should at least have a very low threshold to do that, right? SBP is not a diagnosis just to kind of watch for a couple days. It's a diagnosis to look for early, and you can save some morbidity and mortality with that. And we should say before we move on, if you want this exact study guide, this document that we are going through for this episode, it is available on our Patreon page in our Patreon community. You can download it, annotate it, do whatever you want with it. And all the study guides, all the documents from all of our episodes, at least as of late, are all on that Patreon page. We're really proud of it. You know, we've been trying to grow this Patreon emergency critical care community, and it's finally starting to take off, which is so exciting. There's over 1,000 members. Not only does it have these study guides, but it has all the videos ad-free. It also has ICU one-pagers, clinical reviews, practice questions every other day, kind of medical education posts on emergency critical care topics, mini courses, and a lot more. So if you're interested, it's probably one of the larger collections of emergency critical care medical education out there at this point, and we're planning on just continuing to grow it like crazy. So definitely check that out if you're interested. We'll link it in the episode description as well as the pinned comment on YouTube. All right, core definition of SBP. So SBP is diagnosed when the acidic fluid has a PMN. This is a polymorphonuclear, we cannot speak, a nucleated cell count of more than 250 cells in that acidic fluid, right? This is neutrophilic cells of 250 in this acidic fluid. So oftentimes when you get the cell count, they'll tell you how many cells there are. Let's just say they say there's 1,000 cells. What you have to look for now is the percent neutrophils, right? And if the percent neutrophils is 25% of 1,000, that'll be 250 PMNs, okay? So that is the diagnostic criteria for SBP. Now, it gets a little bit more complex because sometimes you have less than 250 cells, but you have a positive culture. That can support a diagnosis of SBP as well. Either of these things can. And when you have acidic fluid with a PMN count of greater than 250 cells, but the culture is negative, we sometimes call that nutracetic ascites. ascites, and you treat it like SBP, right? You do not need a positive culture to treat SBP. Use that cell count that is well established, okay? Where it sometimes gets a little more tricky is you get that cell count back and it's less than 250 cells, and you're like, oh, not SBP. And then a day and a half later, the culture pops positive. This is called bacteriocides, aka you have bacteria in your ascites. The management of this can be a little more gray. Depends on symptoms, depends on repeat testing, depends on a couple of things, because some patients will just clear this on their own. But the one rule here is that if the patient is symptomatic, they generally should be treated if their cultures grow positive. Okay, hopefully that makes sense. Nutracetic ascites versus bacteriocides. And if you have more than 250 neutrophils in that, you should treat SBP independent of the culture. If you have less than 250 neutrophils and you have a positive culture, you're probably going to treat it, but there is some gray and some nuance there. Do remember, if the tap is bloody, you have a bunch of red blood cells in there, you need to correct the PMN count. So you subtract 1 PMN for every 250 red blood cells. So let's say you have 2,500 RBCs. We're going to try to do math live. You'll do 1 PMN for every 250 RBCs. So this would be, you subtract 10 PMNs from that cell count. So let's say you had 251 PMNs. You would be subtracting 10, which means you really are only considering 241 PMNs, which, again, we're kind of parsing hairs, but technically that would not be considered SBP because it's less than 250 PMNs. All right, pathophysiology here. SBP usually begins with bacterial translocation from the gut. That is a key. Our gut is full of bacteria. And when you have all that ascites, it's kind of like bacterial broth in the belly. Bacteria translocate from the gut into that ascites, right? And it's caused by portal hypertension, increased gut permeability, impaired immune function, bacterial overgrowth, frequent healthcare and antibiotic exposures. All these things contribute to the risk for SBP and how those bacteria translocate over there. So they cross the intestinal lumen. They sometimes get in the lymphatic, sometimes get into the bloodstream, and then sometimes seed the acidic fluid. And they could just grow like mad then. So because of that, the classic organisms you're going to expect are going to be enteric gram-negative bacteria, right? Bacteria that live in the gut, things like E. coli, things like Klebsiella. But in this day and age, we're seeing increasing numbers of less common or non-enteric bacteria, gram-positive organisms, multi-drug resistant organisms, especially if this is a nosocomial or healthcare-associated infection. So we're going to get into that a little bit more, but most classically, you're going to be growing enteric organisms like E. coli or Klebsiella. So when should we suspect SBP? Well, SBP can be obvious. Someone can come in with peritonitis and sepsis, or can be extremely subtle and quiet. So you have to have a broad net. You got to cast a broad net. You should consider SBP in every patient that comes in with cirrhosis and ascites. Right? Some of these patients are going to be obvious. They're going to have a fever. They're going to have abdominal pain. They might have abdominal symptoms, nausea, vomiting, ileus. Others might be more subtle. The SBP might be triggering encephalopathy or AKI, or hypotension, or an elevated lactate, or worsening liver tests, unexplained clinical deterioration. So the key here is you just got to have a low threshold, right, for testing. Right, you got to keep your spidey senses up in any patient with cirrhosis and ascites who's coming to the hospital, which is why the recommendation is to really do a lot of diagnostic paras, even if you are not highly suspicious for SBP. So that is obviously how we're going to diagnose SBP, diagnostic paracentesis. As we said, it should be performed in any hospitalized patient with cirrhosis and ascites, and certainly any hospitalized patient with cirrhosis and ascites and any other symptoms, fever, pain, encephalopathy, AKI shock, GI bleeding, clinical deterioration, etc., etc. What are we going to send the paracentesis fluid for, the acidic fluid, the peritoneal fluid for? Well, obviously cell count differential and culture. These are key. In a perfect world, the culture, you would inoculate the acidic fluid directly into blood culture bottles at the bedside after you do the para. That doesn't always happen, but that would be best practices. And then the other things you can consider sending would be based on the clinical context, right? Is this new ascites where you got to work up what the ascites is coming from? You might be calculating a SAG, or you're worried about secondary peritonitis where you want to send a glucose and an LDH to help you risk stratify. But the minimum tests if you're really like, oh, this is a known cirrhotic with known ascites, I'm not worried about secondary peritonitis, cell count differential and culture would be the minimal test to send. All right. You should not withhold antibiotics if you are going to, do a paracentesis, right? You shouldn't be like, I'm going to do a para tomorrow, so I'm going to hold antibiotics even though they look like they have SBP. But in the clinical arena, this is much more gray and nuanced, right? So if the patient is unstable, you should be giving antibiotics, right? You should not delay them if you think they have SBP. But if you're kind of in the gray and the patient's coming in for AKI and they have no symptoms of SBP, then maybe that's a patient where obtaining ascitic cultures before antibiotics would be feasible. But you got to walk this line carefully. There's a risk waiting if you're missing SBP. So how do we treat it? Well, once SBP is diagnosed or strongly suspected, obviously start antibiotics promptly. There's an infection of bacteria treated with antibiotics. The type of SBP or, how we think they acquired SBP is going to drive those antibiotics, as well as if they have any history of resistant organisms. So run-of-the-mill community-acquired SBP, common empiric options tends to be third-generation cephalosporins. Most commonly is probably ceftriaxone, but cefotaxime is another option. And this is because, right, most of the organisms you're going to grow in a community-acquired SBP are going to be those enteric organisms, Klebsiella, E. coli, etc. Now, if you have healthcare associated or nosocomial SBP, patients with prolonged stays who develop SBP in the hospital, or maybe they got tapped, it was negative, and then they developed SBP thereafter, you're going to have to broaden coverage, right? So has the patient been recently hospitalized, prior resistant organism, septic shock, recent broad spectrum antibiotics, SBP while on prophylaxis, high MDR local rates, all that stuff? When we're thinking about pneumonias as well, are they at risk for MDR organisms? In these cases, you might broaden patients, still targeting gram-negative, but also providing some gram-positive coverage, right? Think about your local antibiograms, all that kind of stuff. So most patients with run-of-the-mill community-acquired SBP are fine with ceftriaxone, but do risk stratify them for more significant or MDR organisms. All right, other management strategies. So we've given them their antibiotics. Another thing to note is albumin in these patients has been shown to reduce the risk of renal failure and mortality. So you should be giving these patients albumin. So obviously you're going to be giving them their antibiotics, but also give them albumin. This is not medical advice. This is just medical education, but a classic regimen you could consider the 1.5 grams per kilogram on day 1 and 1 gram per kilogram on day 3. So it's kind of weird, right? Many institutions have order sets that just do this automatically, but day 1 and day 3, they should be getting that albumin in addition to their daily antibiotics. Albumin is especially important when patients have concomitant renal dysfunction, right? These patients are at high risk for AKI, HRS. We actually did a whole episode on HRS, so if you're interested, definitely just search Whiteboard Medicine HRS and it'll pop up. But this is a common trigger for HRS, so albumin is important, okay? Do not miss it. It does decrease renal failure and improve mortality. Do we do repeat paracentesis? Well, it depends on the clinical context. Often, you can do a repeat diagnostic paracentesis 48 hours after starting therapy, but this is most firmly recommended in those critically ill or those with nosocomial infections or previous resistant organisms or those not improving. You don't necessarily have to do this on every patient, but certainly in these patients that are super sick or you're worried they have resistant organisms or they're not getting any better, you should consider a 48-hour interval diagnostic paracentesis. If that PMN count falls by at least 25%, that is suggestive that you're doing a good job treating it. If it does not, you should be concerned for a resistant organism, inadequate source control. Is this actually secondary bacterial peritonitis, right, from an intra-abdominal surgical emergency rather than spontaneous bacterial peritonitis? Every once in a while, you can get a fungal infection in your acidic fluid, right? So is it fungal in origin, or is there just something else going on? So think about doing that interval paracentesis. Look for that 25% or more decrease in PMNs. And if you're not seeing that, consider, are you under treating or do you not have source control or is something else happening? That leads nicely into secondary bacterial peritonitis. This is compared to what we've been talking about, which is spontaneous bacterial peritonitis. We just wanted to shout this out so that you kind of know it exists, although we're not going to do a deep dive on it. But secondary peritonitis is acidic fluid that's infected because of an intra-abdominal source. That may require something like a surgery, right? They have a perforation, they have an abscess, they have ischemic bowel, they have a biliary catastrophe. So there's something else leading to the bacterial peritonitis. It wasn't just spontaneous, it was secondary to something. And in these patients, right, they usually have peritonitis, peritoneal signs. If you have a culture that's polymicrobial, you did a para and it grew multiple bacteria, that can suggest that sometimes it's secondary, not spontaneous. A very high PMN count, poor response to antibiotics, or if you did send glucose and LDH, the glucose is usually low, less than 50. LDH is usually high. There is something called Runyon's criteria, RUNYONS, which is, protein, acidic glucose, and acidic LDH. And you can calculate this to help you risk stratify for secondary peritonitis rather than primary, so don't be shy. You can find the full score online, I'm sure. These patients, if they do have secondary peritonitis, they need broader antibiotics and urgent imaging with surgical consultation, right? So again, we're not going to do any more deep dive on secondary peritonitis, but just wanted to shout out that it exists. Back to spontaneous peritonitis. So after you've diagnosed it, you've treated it, you've done your interval diagnostic paracentesis, the PMNs decreased by more than 25%, the patient is getting better. They do recommend SBP prophylaxis. So there's kind of primary and secondary. Secondary prophylaxis is related to the case we talked about. Someone had diagnosed SBP, and afterwards, to reduce the risk of recurrence, because the risk is really high if you've had it once, these patients should be on long-term secondary prophylactic antibiotics, right? This can be ciprofloxacin, this can be trimethoprim sulfamethoxazole. There's other regimens kind of based on your local antibiogram, but they should be on this because they're really high risk for recurrence. There's also, and that's called secondary prophylaxis, right? You already had SBP, now you're secondarily trying to prevent it from happening again. There also is criteria for primary prophylaxis. These are in cirrhotics who have not had SBP. There's criteria here, and you certainly can find them, but you can consider it in patients with a really low acidic protein, often less than 1.5, plus high-risk features like renal dysfunction, hyponatremia, or advanced liver failure. So something to just note, right? There's a small subset patient population that would benefit from primary prophylaxis for SBP with prophylactic antibiotics, but if you have had SBP, you should have secondary prophylaxis to prevent recurrence. Some critical care considerations here. SBP is a trigger for a lot of stuff: septic shock, acute kidney injury, hepatorenal syndrome, hepatic encephalopathy, respiratory failure, acute on chronic liver failure. So this is a common trigger for these things, and as such, it needs to be addressed, right? So if someone comes in with HRS, right, we should be thinking, is it triggered by SBP? Or someone comes in with hepatic encephalopathy, same thing. Or someone comes in septic, same thing, right? Is it caused by SBP? Key priorities are early paracentesis, appropriate antibiotics, think about resistance patterns, and obviously supportive care, because SBP can prompt a lot of decompensation, like we talked about. All right, we're getting towards the end here. We're going to talk about some common pitfalls, some take-home points, and then we'll have our 3 practice questions to see if we learned anything. Pitfall number 1, waiting for abdominal pain. This is huge, right? Oh, they don't have SBP, their abdomen doesn't hurt. SBP can present without dramatic abdominal findings. We got to be really careful about anchoring on severe abdominal pain. Now, if they do have abdominal pain, suggestive, right? But if they don't, that does not rule it out the same way. It might, almost rule out other intra-abdominal pathologies. Pitfall number 2, not doing a paracentesis, right? A diagnostic paracentesis, if done right, is low risk and high yield. Even in potential coagulopathy or thrombocytopenia, you still often, depending on the degree and what's going on, can do a paracentesis. So do not delay tapping someone who you've admitted with decompensated cirrhosis and ascites, barring other clinical circumstances, right? Obviously, there's limits to that statement. Okay, pitfall number 3, treating culture negative SBP is not real, right? SBP diagnosis is PMNs greater than 250 cells. Treat it, right? Even if the culture is negative, you should still treat it. And then pitfall number 4 is missing secondary peritonitis, right? Patients with decompensated cirrhosis can still have other intra-abdominal emergencies. So if they're not responding to your antibiotics, their cultures are polymicrobial, or you do Runyon's criteria, and it looks like it could be secondary, make sure you're doing aggressive imaging and surgical consultation. And then last pitfall number 5, forgetting prophylaxis after recovery. Everyone with SBP should have secondary prophylaxis to prevent recurrence. So take-home points, SBP is an infection of the acidic fluid without a surgically treatable intra-abdominal source. Diagnostic threshold is PMNs greater than 250. Every hospitalized patient with cirrhosis and ascites should be considered for diagnostic paracentesis. Treat promptly with empiric antibiotics. Tailor to community-acquired SBP versus healthcare-associated or MDR organism risk. Albumin is important. They should be getting albumin. This reduces renal failure and mortality in high-risk SBP patients. Those at high risk or critically ill or not responding how you think they should have a repeat paracentesis 48 hours after initiation of therapy, looking for that PMN count to decrease by more than 25%, and always rule out if there's any other secondary intra-abdominal source. All right. Last but not least, we have 3 practice questions, and then everybody can go enjoy their day. The way these practice questions work is one's beginner, one's intermediate, one's advanced. We'll read the question, read the answer option, and then we go right into the answers. So if you need more time to think about it, just make sure you pause the episode because we're going to jump right into the answer. So question number 1. A 61-year-old man with cirrhosis and ascites is admitted for confusion and worsening renal function. He is afebrile and denies abdominal pain. Diagnostic paracentesis was done, which is excellent, and it shows 420 PMNs with negative cultures. What is the best next step? A. Observe without antibiotics because the culture is negative. B. Treat for spontaneous bacterial peritonitis. C. Repeat paracentesis in 1 week before deciding. Or D. Diagnose malignant ascites. Pause if you need to. The correct answer is B. Treat for spontaneous bacterial peritonitis. Remember, the acidic fluid count here was, 420 PMNs. More than 250 PMNs is diagnostic, independent of the culture, and it should be treated. All right, question 2. A patient with cirrhosis is diagnosed with SBP. Creatinine's 1.8 and bilirubin is 5. In addition to antibiotics, which therapy has been shown to reduce renal failure and mortality in high-risk SBP? A. Albumin. B. Furosemide infusion. C. Therapeutic anticoagulation. Or D. Lactulose loading. Pause if you need to. The correct answer is A. Albumin. Albumin is recommended in SBP, especially in patients at higher risk, such as those with elevated creatinine or bilirubin. Classic regimen is 1.5 grams per kilogram on day 1 and 1 gram per kilogram on day 3. All right, last question. A 54-year-old woman with cirrhosis is treated for presumed SBP. After 48 hours of antibiotics, she has worsening abdominal pain and persistent shock. Repeat paracentesis shows minimal decline in PMNs. Acidic studies reveal protein of 1.4 grams per deciliter, glucose of 35 milligrams per deciliter, and LDH above the serum upper limit of normal. What is the most important concern? A. Culture negative nutracetic ascites responding appropriately. B. Secondary bacterial peritonitis from a surgically treatable source. C. Uncomplicated bacteriocides. Or D. Hepatic hydrothorax. Pause if you need to. The correct answer is B. Secondary bacterial peritonitis from a surgically treatable source. This patient is not responding to their antibiotics, and per Runyon's criteria, right, they have an acidic protein greater than 1, a glucose less than 50, and LDH above the serum upper limit of normal. This should raise concern for secondary bacterial peritonitis. Urgent imaging, broad antimicrobials, and surgical consultation should be the next steps. All right, that is all we have for you today. Thanks for checking it out. Let us know what thoughts, comments, questions you have down below. Again, we'd love for you to check out our Patreon community. We'll actually have a little video at the end of this episode where we go through some of the Patreon community if you want to see it with your own eyes. Siri was spying on us. In addition to that, we have an awesome YouTube members community too that you can join. And either way, even if not, stay well, keep learning, and we hope to see you next time. Today's topic is one that is very important for emergency critical care. And it's one that you're probably bound to see, although it is somewhat dependent on where you end up practicing or where you provide care to patients. If you are anywhere near a liver center or take care of patients with cirrhosis, then you definitely will. And it's something you'll be talking about probably daily, trying to navigate the complexity of it. And that is hepatorenal syndrome, or HRS. So in this episode today, we're going to go through all things HRS. It's going to be a deep dive focusing on kind of the emergency critical care applications of HRS. As always, here's our disclaimer. None of this is intended to be acted upon as medical advice. All of it is just for educational purposes only. No further ado, hepatorenal syndrome. So why does this matter? Well, hepatorenal syndrome, or HRS, which is probably what we'll to use for the rest of the episode just to save ourselves some extra words. But HRS is one of the kind of highest stakes kidney emergencies in patients with advanced liver disease. There's lots of effects on morbidity and mortality in these patients. And at the bedside, the key concept is really simple. The kidneys in HRS are still structurally capable of working. It's not an intrinsic injury to the kidney, at least not right away. But really what is happening is the circulation is so deranged that renal perfusion, kidney perfusion starts to become compromised. And that is what prompts HRS. HRS is a functional renal failure driven by severe portal hypertension, splanchnic vasodilation, systemic inflammation, and intense renal vasoconstriction. And these four things, right, portal hypertension, splanchnic vasoconstriction, systemic inflammation, and renal vasoconstriction are all things we're going to dive deeper in. And we should say before we get further, if you want this exact study guide, this exact document, what we are going through in this episode, it is accessible, downloadable, you can annotate it, do whatever you want with it on our Patreon page and our Patreon community. All of these study guides from all of our episodes, at least the latter, couple hundred of them, are all in that Patreon community. And, we're really excited about it. It's probably grown to be, one of the larger collections of emergency critical care medical education content out there. Not only do we have these study guides, but all the videos are on there ad-free. We have ICU one-pagers. We have practice question banks. We have clinical reviews, which is kind of a cluster of study guides on different foundational topics. We have mini courses on medical education posts every other day, tons of stuff. And we've been so grateful. There's over 1,000 members on there now. So if you're interested, definitely check it out. It'll be linked in the episode description as well as the pinned comment. But yes, back to the episode. So for emergency critical care clinicians, anyone who is at the bedside helping take care of these patients, or who are still a student or trainee kind of learning how to take care of these patients, HRS is quite challenging. And that challenge is that HRS looks like many other causes of AKI, right? Acute kidney injury, but trying to navigate whether it is HRS or something else, hypovolemia, hypervolemia, nephrotoxicity, ATN, what have you, can be really, really challenging. And it does affect management, right? Depending on what is causing this AKI. HRS has a distinct kind of cocktail of therapies to try to help that renal function improve as compared to other causes of AKI. So I think if we were to, try to just put this into a category of what should we be looking for right off the bat, I think the job, is that we don't just spot HRS instantly. We recognize acute kidney injury and cirrhosis. We stabilize the patient. We reverse any triggers. We exclude competing diagnosis. And then once we do that, we start disease-specific therapy for HRS. And we'll get into all that nuance more. All right, let's start by defining HRS. Well, HRS is acute or chronic, and we're going to be focusing on acute today, but acute or chronic kidney dysfunction occurring in advanced liver disease, usually cirrhosis, and most of these patients have ascites as well. There's some intermixed pathophysiology going on there. In the absence of another explanation for renal injury, and that is key, right? This is acute or chronic kidney dysfunction, advanced liver disease, often cirrhosis, in the absence of another primary explanation for that renal injury. In the old verbiage, the old terminology, actually the terminology that we learned, actually had two different subtypes of HRS that they called type 1 and type 2. We have veered away from that now, and the current categories, which are the type 1 and type 2, are HRS-AKI and HRS-NAKI, right? So this is HRS-AKI and HRS-NAKI instead of type 1, HRS, and type 2. Now depending on when people trained and, how up to date and stuff they are, people still use the verbiage type 1 and type 2, but kind of the more formally endorsed and discussed now is HRS-AKI and HRS-NAKI. So HRS-AKI, or the old type 1, is an acute rise in creatinine in a patient with cirrhosis, and we have ruled out those other causes, right? So it's not from shock, it's not from nephrotoxin, it's not from structural kidney disease. And this is the primary phenotype we're going to be talking about today, right? This is the one more relevant for emergency critical care medicine. But just to shout out HRS-AKI, or type 2 HRS, this is a NAKI, non-acute kidney injury form of HRS, right? This is a patient with cirrhosis who has more gradual kidney impairment over time, and it's often associated with refractory ascites. But for the sake of this episode, again, we're not going to be focusing on HRS-AKI. We're going to be talking about this type 1, this HRS-AKI. So what is the pathophysiology? Understanding HRS and understanding how to diagnose it and the therapies for it is all circles back to the pathophysiology. So this is incredibly important to understand. So HRS starts with advanced cirrhosis, and part of that is patients have to have portal hypertension. This is kind of a foundational principle. So if we don't have a good grasp on portal hypertension, it'd be worth going back and looking at that, because a lot of the pathophysiology we're going to talk about stems back to portal hypertension. And, just briefly, portal hypertension is quite literally hypertension in the portal system, right? If we draw a liver here, you have your portal system, blood flows into the liver. If this liver is all fibrosed and cirrhotic, trying to flow blood through that liver is going to be harder. There's going to be more resistance. This is going to increase the pressure in the portal system and lead to portal hypertension, right? And that portal hypertension backflows into a bunch of stuff and causes a bunch of issues. So the first part of the pathophysiology here is that portal hypertension and splanchnic vasodilation. So portal hypertension leads to vasodilation of the splanchnic circulation, right? This is kind of the mesentery, the guts. And this is because of different local mediators, right? Cirrhotics secrete much more nitric oxide and other vasodilators. And this then reduces the effective arterial blood volume, because blood starts to pool in the splanchnic circulation in that mesentery. And as blood pools there, there's obviously less circulating blood in the arterial system. That's why these patients sometimes will look very extravascularly volume overloaded, right? They have ascites, they have peripheral edema, they have pleural effusions, but their arterial circulation is actually kind of hypovolemic. It's underfilled. It's one of those really difficult challenges. People sometimes say that these decompensated cirrhotics are total body volume up, but effective arterial volume down. So the first kind of principle here is splanchnic vasodilation, and the relevance of that is that then leads to pooling of blood in the splanchnic vasculature or the mesentery, which then actually decreases effective arterial circulating volume, right? And that's what perfuses the kidneys, is that arterial volume. So if there's less effective circulating arterial volume, there's going to be less blood perfusing and going to the kidneys. Okay. The second principle here is related to neurohormonal activation. So the body, to try to compensate for this decrease effective arterial volume, activates the renin-angiotensin-aldosterone system, or the RAS system. It also activates our sympathetic nervous system and vasopressin pathways, right? All these get activated, they all go up. And these mechanisms are meant to maintain perfusion over time, right? You hold on to more sodium, you try to reabsorb more volume into your vasculature, you vasoconstrict, right? All this stuff. But as these spiral out of control, they become maladaptive and lead to the next principle, which is renal vasoconstriction. So the renal blood vessels, the perfusion to those kidneys starts to constrict intensely. And this is related to that neurohormonal activation, right? Your body thinks there's not enough circulating arterial blood volume, and there actually isn't, because it's all pooling in your splanchnic circulation. So you vasoconstrict, and that includes the blood vessels to the kidneys. But as they vasoconstrict, you get less perfusion to the kidneys, and that GFR, that filtration rate of the kidney, starts to fall. This then leads to worsening sodium and water retention right through that RAS system, and that sodium and water retention worsens ascites, and it can worsen hyponatremia. So this is all, you kind of see how the spiral is starting. You get pool, you get increased nitric oxide and other local vasodilators in the splanchnic circulation that causes pooling of the blood in that splanchnic circulation. That leads to less circulating arterial blood volume, which then causes your body to activate the RAS system, the sympathetic nervous system, the vasopressin pathways. This then leads to renal vasoconstriction, right? Because your body is trying to vasoconstrict to preserve that systemic blood pressure. That renal vasoconstriction then leads to more sodium and water retention, and the circle keeps going around. And then the last thing, which is kind of less tied into this nice series of pathophysiologic steps we talked about, is just general systemic inflammation and cardiac dysfunction. Cirrhosis is not just the vascular plumbing problem we talked about, but you get bacterial translocation, systemic inflammation, adrenal dysfunction, cardiomyopathies, all that stuff, and all these little things add up over time and can lead to worsening kidney injury. So this is like one of the reasons that HRS is usually prompted by a precipitating event. Just like many things in cirrhosis, we talked about esophageal variceal bleeding, hepatic encephalopathy, all on this channel. Just search whiteboard medicine, insert whatever topic you want, and odds are we got an episode on it somewhere. But HRS, just like these things, usually has a precipitating event, something that prompts the decompensation for HRS-AKI, we should say, which again is what we're talking about in this episode. And that's sometimes infection, that's sometimes GI bleed, that's sometimes large volume paracentesis, aggressive diuretics, drinking and getting kind of acute on chronic hepatitis. All these things can be kind of the straw that broke the camel's back and tip those kidneys over the edge, right? The kidneys are kind of caught in that crossfire. So hopefully that pathophysiology makes sense, because a lot of what we're going to do to manage HRS is going to be related to that. So if you have questions, certainly let us know in the comments. We'd be happy to answer them. So we talked about precipitating events, and anytime you have someone with decompensated cirrhosis who has hepatic encephalopathy or who has HRS, you always want to look for a trigger to make sure you're not missing something underlying. And the common precipitants for HRS are honestly very similar to the precipitants for something like hepatic encephalopathy. Any infections, whether that's spontaneous bacterial peritonitis, pneumonia, cellulitis, skin soft tissue infection, GI bleeding, too much diarrhea from the lactulose you're using to treat the hepatic encephalopathy, large volume paracentesis without adequate albumin, and then different medications, right? Sepsis, shock, ACE, ARBs, NSAIDs, IV contrast is on here, although whether that's true or not is an open question. And then just worsening decompensated cirrhosis with worsening portal hypertension. Any of these things can be kind of that trigger that can lead to HRS. And you don't want to miss the trigger, because if you don't fix the trigger, you're not going to be able to fix the HRS. So anytime you have HRS, it's great to diagnose it, and it's great to initiate management therapies to try to lead to renal recovery and treat that HRS. But you also have to think, what is the trigger? Like so many things in medicine, right? DKA, HHS, all this stuff, triggers prompt this pathophysiology, and figuring out if there is the trigger, what it is, and addressing it is just as critical as treating the HRS itself. All right, what's the clinical presentation? What do we usually see? Well, HRS is kind of mysterious, right? There's not one signature symptom. It's usually a collection of symptoms. Things like increasing creatinine, decreased urine output, right? This is just normal acute kidney injury stuff. But there's some hints just in terms of general kind of decompensated cirrhosis that can lead you to know a patient is at much higher risk for HRS, right? Patients with tense ascites, a lot of kind of extravascular fluid buildup like peripheral edema, jaundice, encephalopathy, recent infections, right? All these are things that suggest there's worsening decompensated cirrhosis that then place the patient at increased risk for HRS. And another thing, and I think we talk about it at some point later on, but remember, a lot of patients with cirrhosis have decreased muscle mass, so their creatinine sometimes are quite low to start. So if someone comes in and their creatinine is, depending on what units and where you practice, but 1.1 in, the US, their baseline creatinine, right? Their baseline creatinine honestly might be like 0.3. So this is a huge jump as compared to a bodybuilder. Their creatinine being 1.1 is probably just their normal. So just note that, right? A lot of cirrhotics have decreased muscle mass and live with a lower creatinine. Okay, so dangerous pattern recognition stuff, cirrhosis, tense ascites, rising creatinine, low effective circulating volume without other causes of acute kidney injury. This is where the money's at for HRS. So what's the diagnostic approach then? We spent a lot of time saying, it's really hard to pin it down to one single thing, one single symptom. But how do we diagnose it? Well, it's honestly just as difficult, right? HRS is a diagnosis that is made in context. It's not diagnosed by one single lab value. So the first step is the obvious step. Confirm that the patient's got acute kidney injury to start with, and obviously cirrhosis. As we said, in cirrhosis, small creatinine changes matter, right? So acute kidney injury, per the normal typical definitions out there, an increase in serum creatinine by at least 0.3 milligrams per deciliter within 48 hours, or an increase to at least 1.5 times the baseline within the prior 7 days. This is just normal. We think it's probably KDIGO, although correct us if we're wrong on which organization put forward that definition, but just normal AKI definitions. And then do note, as we said, creatinine underestimates renal dysfunction in cirrhosis because patients also often have that low muscle mass and may have a reduced creatinine generation to start with. All right. Step 2. So you've confirmed acute kidney injury and cirrhosis. Step 2 is determine whether this is HRS or something else. And this is the really hard step, right? It could just be pre-renal azotemia, it could be ATN, it could be sepsis-associated AKI, glomerulonephritis, bile nephropathy, right, et cetera, et cetera, et cetera. We don't need to read them all out loud, but it could be decompensated cirrhotics, just like any patient can develop AKI from all those other things that patients can develop AKI from, acute kidney injury. So we have to start navigating that. And the way we can navigate it is to start ruling out other diagnoses, right? Make sure they don't have obstructive nephropathy from, benign prostatic hyperplasia, hypertrophy. Oh, goodness. And that their bladder isn't full of 1.5 liters of fluid, right? Make sure that they're not just hypovolemic, all that good stuff. Look for things that would not add up to HRS, right? So does the patient have significant structural kidney disease, proteinuria, hematuria, active urine sediment, and abnormal renal ultrasound? So start to rule out those other causes with that low-hanging fruit. And if you start to rule out those other causes, then at this point, look for some criteria that could further support HRS. And this would be, in a perfect world, cirrhosis, ascites, AKI. The patient's not in shock. They have no recent nephrotoxin exposure. They have no structural kidney disease. And they have not had improvement with plasma volume expansion. And this is a key here. Historically, the recommendation has been to albumin challenge cirrhotics with AKI before you call it HRS, right? So stop diuretics, give albumin often 1 gram per kilogram per day, up to 100 grams per day for 2 days. This, sometimes equates to something like 25 grams TID for 48 hours, depending on the weight of the patient. And many of these patients that were like, they must have HRS, they actually get better with this intravascular volume buffing, and they were actually just pre-renal hypovolemic, which is not uncommon. But where we get an HRS is we have a cirrhotic with acute kidney injury, we've ruled out other causes, we albumin challenge them without improvement in their creatinine, and then we can say this is HRS-AKI, or at least it might be, and we should probably treat it. Do know that, whether you wait the mandatory 48 hours in every patient is somewhat unclear, right? You don't want to delay things too long. But in clinical practice, depending on the clinical scenario, it is not unreasonable to do that 48-hour albumin challenge, although take it all in clinical context per usual. Some bedside evaluation stuff. We're not going to spend too much time on this. A lot of it is kind of straightforward stuff. If you end up downloading the study guide off our Patreon page, all this is listed there, but normal labs, right? CMP, CBC, INR, lactate if they seem sick, do an infectious workup, do urine studies, urine lights, image their kidneys, see if they have ascites, just normal stuff. We did want to pause on this though and shout this out. So urine sodium and FeNA. So traditionally, HRS is associated with a very low urine sodium. So this is one of the tests that can be helpful. You send a urine sodium. In the US at least, the assay sometimes says less than 12. This is a very low urine sodium. Or you get a FeNA and it's a low FeNA. This is supportive of HRS, but not diagnostic of HRS, because in cirrhotics, sometimes this is low even in ATN, especially early ATN, before those tubules are fully destroyed, and then you start leaking more urine sodium out. And then a lot of these patients are on diuretics, which can distort the interpretation. So a low urine sodium supports HRS, but it does not prove HRS. Just to note, but this is something you should send, right? It's something you should send. It's another kind of piece of data within the larger specter. And if it is low, it can support a diagnosis of HRS if the rest of the clinical context is aligned. Also, just like FYI, this is in every single episode we do related to decompensated cirrhosis. If the patient has ascites, they need a diagnostic paracentesis. Full stop. That's it, right? Any hospitalized patients with cirrhosis and ascites should get evaluated for SBP. If there is SBP, this is one of those triggers for HRS, and we should be aware of that, and it can be helpful down that diagnostic path. All right, initial management of HRS. Well, the first thing, stop the offending agents. Any nephrotoxic agents, stop them. We want to give the kidneys every shot we can in trying to recover. Treat any of those underlying triggers. Treat infections, right? Especially SBP. SBP is maybe common is too aggressive of a word, but definitely something you'll run into. So treat SBP, treat other infections. Give albumin. Now, this is something that is part of the cocktail treatment for HRS. In HRS-AKI, again, none of this is 10 be medical advice. This is all just for educational content. Check your local guidelines, et cetera, et cetera. But some would state albumin 1 gram per kilogram per day, max 100 grams per day over 2 days. And then if they have SBP, obviously there's a different albumin approach. But do note, albumin isn't harmless, just like any medication is not harmless. Watch the patient's volume, watch them for volume overload, reassess them, all that good stuff. But albumin. And then we broke this up in kind of an odd way in retrospect, although it'll still work. I guess that's initial management. Treat the underlying trigger, stop nephrotoxic agents, and start your albumin. And now we will get into the disease-specific therapies for which albumin is considered one of them, but we'll kind of break it anew here. So the core pharmacologic treatment for HRS-AKI, that's what we're going to talk about now. This is big-time bread and butter management strategies. So the goal here is to reverse that pathology, right? That pathologic splanchnic vasodilation, improve the effective arterial volume, and increase renal perfusion. Because as we said, that is the pathology that is going on. We have splanchnic vasodilation that is leading to pooling of the blood in the splanchnic vasculature, that is leading to a decrease in arterial volume, that is leading to decreased renal perfusion, and the kidneys vasoconstricting, so renal vasoconstriction to try to buff up that systemic pressure, and that is then causing that circle to flow round and round again. So what we want to do is we want to reverse that splanchnic vasodilation. We want to improve effective arterial volume and increase renal perfusion. So the ways in which we do that tend to be a splanchnic vasoconstrictor, albumin. Obviously fixing their cirrhosis is great too. And then I guess definitive therapy is transplant, that we'll talk about later. It's not going to be in this section. The first medication that we talk about, not available everywhere, but is terlipressin. Terlipressin is a vasopressin analog. It is FDA approved in the United States. It does have an FDA label for safety endpoints, and we have them listed here. Most of it is respiratory failure related. So it can cause serious or fatal respiratory failure, avoided in hypoxemic patients, avoided in patients with volume overload. It is contraindicated in ongoing coronary, peripheral, or mesenteric ischemia, or patients with super bad HRS with a creatinine greater than 5. What this does, though, is it causes that vasoconstriction. Okay. Another medication if the patient is in the ICU, which is often the case for us, is norepinephrine, right? Norepinephrine has alpha-1 effects that cause vasoconstriction, and you can titrate it to what you want. So in either of these cases, the goal here is that we are trying to raise the mean arterial pressure, right? So you want to increase the MAP. What you increase it by is, not totally known, but somewhere in the realm of kind of 10 to 15 millimeters of mercury above what they were. The goal here is to try to improve renal perfusion while avoiding ischemic complications, right? So you kind of want to walk that line. And you can do this, raise the map using terlipressin. You could do it using norepinephrine. You could do it using midodrine. We actually have whole separate episodes out on norepinephrine and midodrine. Just search Whiteboard Medicine, norepinephrine or midodrine or what have you. You could dive into those as you see fit. Okay, another therapy to think about is octreotide. Octreotide is, Octreotide helps shunt some of that splanchnic circulation towards the systemic circulation. Often on the floors outside the ICU, you get that cocktail of midodrine and octreotide with the albumin we talked about before. I guess we can't say this for sure. Terlipressin is not widely used, at least in the US. Correct us if we're wrong. Maybe everybody's using it and we just are outdated. But last we looked into this and we've been at some different institutions. Terlipressin is not widely available. So on the floors, you usually get this kind of midodrine, octreotide, albumin combo. In the ICU, instead of midodrine, sometimes we have norepinephrine with octreotide with albumin for that HRS-AKI cocktail. All right, critical care priorities related to this. MAP matters. Patients with HRS often need higher perfusion pressures. You want to drive that MAP up, right? 10 to 15 millimeters of mercury. Numbers not universal. This should be a multidisciplinary decision with nephrology. If you can, you got to walk that line because too much vasopressors can cause worsening ischemia, but you want to drive that MAP up to try to optimize renal perfusion. Another kind of common thing is respiratory status matters. Remember that giving albumin and volume overload and all these things are important. A lot of these patients third space fluids and get things like hepatic hydrothorax and ascites and peripheral edema, and all this can contribute to worsening respiratory status. So before you're super aggressive, just make sure the patient has kind of enough space from a respiratory standpoint. And then remember, source control matters. Triggers are important. You need to treat the underlying trigger. And then as with any AKI, avoid those nephrotoxins, right? That seems fairly obvious. One thing to note here is related to tense ascites. The abdomen is a compartment. That compartment has the blood vessels that lead to the kidneys. There's this entity known as intra-abdominal pressure, and it could be intra-abdominal hypertension, and this can progress all the way to abdominal compartment syndrome. Okay, so large tense ascites, even if it's not abdominal compartment syndrome, can worsen renal perfusion by increasing the intra-abdominal pressure, and that pushes on those blood vessels and can hurt that renal perfusion. So sometimes paracentesis may improve not just respiratory mechanics, but renal perfusion. But you got to walk that line. If you take a ton of volume off without adequate albumin replacement, you sometimes reduce that circulating volume, and that can worsen renal function. So as with many things with decompensated cirrhosis, you're trying to walk that line, okay? But just note that, right? Someone's got big tense ascites. You might need to remove some of that fluid to try to relieve that intra-abdominal pressure and help renal perfusion. And if you're doing a paracentesis, you know, that common replacement strategy, albumin after removing more than 5 liters, often 6 to 8 grams of albumin per additional liter or per liter removed. Again, there's no necessarily magic to this, but this is kind of the commonly thought approach. If you remove more than 5 liters, give 6 to 8 grams of albumin per liter removed. The definitive therapy here is a liver transplant, right? This is the definitive therapy for most complications of cirrhosis, including HRS. This is why early hepatology and transplant involvement is really important. Obviously, if someone goes into full renal failure, renal replacement therapy can be initiated, although dialysis does not fix HRS. It is just a bridge in selected patients to transplant or recovery from a reversible trigger. So consider it, but this is a multidisciplinary discussion, right? Depending on where this patient is at in their trajectory, sometimes this isn't even a viable option because it's kind of a path to nowhere. At times in a non-transplant candidate with progressive HRS and multi-organ failure, dialysis may not provide meaningful survival benefit, and goals of care conversations become part of that really good critical care approach. All right, prognosis for these patients, we're getting close to the end. HRS-AKI carries a high mortality, especially without liver transplant. Poor prognostic features include, the normal stuff you'd think about: high MELDs, sepsis, need for vasopressors, need for a mechanical ventilation, lack of creatinine response, aka progression to renal replacement therapy, multi-organ failure, severe hyponatremia. These are all somewhat straightforward, obvious things. All right, we'll get into some common pitfalls, take-home points, and then 3 practice questions to see if we learned anything. Pitfall 1, calling every acute kidney injury and cirrhosis HRS. This is so tempting, right? You have a patient with decompensated cirrhosis, they have an AKI. HRS, we have these medications to start: midodrine or norepinephrine or terlipressin, octreotide, albumin, and we're like, yeah, HRS, but most of them are not, right? Many cases are sepsis related, hypovolemia related, ATN obstruction, all those kind of normal AKI things. So you really got to thoughtfully rule that stuff out. And again, in many cases, do a 48-hour albumin challenge before you commit to HRS. Pitfall number 2, though: waiting too long to treat, right? Oxymoron here, but if a patient has HRS and you believe they have HRS, let's say you've ruled out other pathologies, let's say their urine sodium is low, but they're not hypovolemic, delaying HRS therapy can also reduce chance of reversal. Like we said, decompensated cirrhosis, we're constantly walking this line. Pitfall number 3, giving albumin automatically without reassessment. Just remember, albumin is intravascular volume, and it can contribute to third spacing of fluids in different places, including the lungs. All right, pitfall 4, forgetting a diagnostic paracentesis. SBP is so common, it's deadly, it is treatable. You need to address this as a potential reversible trigger. So do that para and treat if it's SBP. And then pitfall 5, using creatinine too comfortably. Remember, creatinine underestimates renal dysfunction and cirrhosis. These patients often have decreased muscle mass, and their creatinine may not be as representative of the degree of kidney injury. So if we could do some take-home points here: HRS-AKI is a functional renal failure from advanced liver disease, circulatory dysfunction, and intense vasoconstriction. The emergency critical care clinician's first job is to identify AKI early, stop nephrotoxins, treat triggers, rule out other causes, avoid anchoring on HRS, but don't drag your feet too long if you think you have the diagnosis. Albumin is central here, but obviously always monitor their volume status. Terlipressin is an FDA-approved drug for HRS, but there's many important respiratory and ischemic risks to consider. Norepinephrine plus albumin plus octreotide remains a major ICU strategy. That norepinephrine is going to be to push that map, somewhere in the 10 to 15 millimeters mercury higher than you would. Definitive treatment is liver transplantation if folks are candidates. And HRS is a renal manifestation of a failing liver, right? That's the key there. All right, should we get into 3 practice questions and then have everybody go enjoy their day? If you've not done practice questions with us before, the way it works is there's 3 practice questions: a beginner, intermediate, and advanced. We'll read the question, read the answer options, then we'll go right into the answer. So if you need more time to think about it, just make sure you pause the episode. Question 1, a 58-year-old man with alcohol-associated cirrhosis and ascites is admitted with confusion and abdominal distension. His creatinine has increased from 0.8 to 1.4 milligrams per deciliter over 48 hours. Blood pressure is 104/62. He has no obvious bleeding. Which of the following is the most appropriate next diagnostic step? A, start ibuprofen for presumed hepatorenal pain. B, diagnostic paracentesis. C, immediate renal biopsy. Or D, fluid restriction alone. Pause if you need to. The correct answer is a B, perform a diagnostic paracentesis. So remember, any hospitalized patient with cirrhosis and ascites, especially one with acute kidney injury, should get a diagnostic paracentesis to evaluate for SBP. This is a common precipitant for AKI and HRS and needs to be promptly treated. You shouldn't be giving NSAIDs to this patient who's got acute kidney injury. You shouldn't be doing a renal biopsy unless you have strong evidence of intrinsic renal disease. And fluid restriction alone is not addressing the underlying precipitant. Cool. Question number 2, intermediate. A 64-year-old woman with decompensated cirrhosis and tense ascites develops AKI. Diuretics are held, nephrotoxins are stopped, and albumin is given. Urinalysis shows no significant proteinuria or hematuria. Renal ultrasound's normal. She's not in shock. HRS-AKI suspected. Which medication strategy is most appropriate in the ICU? A. Norepinephrine albumin. B. Furosemide infusion plus spironolactone. C. Dopamine at, quote, renal dose, end quote. D. Hydrochlorothiazide plus crystalloid. Pause if you need to. The correct answer is A. Norepinephrine and albumin. So this patient has suspected HRS-AKI. You need vasoconstrictor therapy. This could be norepinephrine. This could be terlipressin in certain patients. This could be midodrine plus albumin. And often we add octreotide to that bundle as well. Okay. Norepinephrine is commonly used in ICU settings because it's easier to titrate and push that blood pressure. All right, last question, and then we will be done. A 55-year-old man with cirrhosis, ascites, and suspected HRS-AKI is being considered for terlipressin. He's on 6 liters nasal cannula with a saturation of 88 to 90%, has bilateral pleural effusions, and appears volume overloaded. After multiple albumin doses, appears volume overloaded after multiple albumin doses. Punctuation is important to enunciate. Creatinine is 3.8. Which of the following is the best interpretation of this? A. Terlipressin should be started immediately because creatinine is below 5. B. Terlipressin is contraindicated or should be deferred because of hypoxia and worsening respiratory status. C. Albumin should be doubled before considering vasoconstrictors. Or D. Midodrine monotherapy is definitive treatment. Pause if you need to. The correct answer is B. Terlipressin is contraindicated or should be deferred because of hypoxia or worsening respiratory status, right? Terlipressin has a warning for serious or fatal respiratory failure, advised against initiating it in patients with hypoxia until oxygenation improves, et cetera, et cetera. So yes, terlipressin not good in respiratory failure stuff. Today's topic is one that you almost definitely will see in the clinical arena, but depending on where you work, if it's a liver center, you might see it more than other places. But it's one that's really important, one that when it is mild, it's not that difficult to treat, but when it gets severe, which is where we're going to spend a lot of our time today, it can be really dangerous and really challenging, and that is hepatic encephalopathy. So what we're going to be talking about today is we're going to define what hepatic encephalopathy is, recognize that it has a progression from mild to severe. We'll distinguish hepatic encephalopathy from other causes of altered mental status. We'll talk about some of the pathophysiology behind pneumonia and inflammation, infection, renal failure, what can prompt hepatic encephalopathy, common precipitants, and then we'll dive into the therapeutic interventions that you can do to try to manage hepatic encephalopathy. We'll end with some common management pitfalls, and then as always, we'll have a couple practice questions at the end to see if we have learned anything today. So no further ado, hepatic encephalopathy. What is hepatic encephalopathy? Well, we should say before we start, if you want this study guide, this exact PDF, what we are going through in this episode, all of these are offered on our Patreon page. You can open them, you can download them, you can print them, you can annotate them, you can do whatever you want. All these PDFs and study guides from every episode are on our Patreon page. We have a Patreon community that we've been really excited about. It's been growing like crazy. We've been so appreciative. I think at this point, depending on when you see this episode, there's over 1,000 members in there. And on there, we've been trying to grow a ton of medical education content in emergency critical care medicine for y'all. It's probably one of the biggest collections of emergency critical care medical education out there. We have all these PDFs and study guides, ad-free videos, mini courses, one-pagers, which is kind of a one-page high-yield summary of different clinical conditions, medical education posts, and at the end of the day, it's also a great community of like-minded, I say this with love, nerds like us who are passionate about emergency critical care medicine. So if you have an interest, it is linked in the episode description as well as a pinned comment on YouTube. We'd love for you to check it out. There's free trials and stuff you can do too if you want to dip your toe in the water before you fully join. So, okay, no further ado then, let's actually dive into hepatic encephalopathy. So hepatic encephalopathy, often abbreviated HE, is a reversible, usually, we'll get into a couple scenarios where maybe you might be closer to the end stage, neuropsychiatric syndrome that is caused by liver dysfunction, and the key here is portosystemic shunting, because what's actually happening is you might have liver cirrhosis. And we're going to do a little drawing here. It's going to be a bad drawing. This can be a liver. You have your portal system, which is blood flow into the liver, and then blood travels out of the liver, right, into the systemic circulation. And when you have a fibrosed liver, what happens is you can't really filter that blood the same way. So the blood travels through the liver. It's fibrosed, so you get increased portal pressures, right, because it's harder to push blood through that liver. And you don't have as effective filtration of that blood. So the blood returning to the systemic circulation is somewhat somewhat shunted, right? It doesn't have as much travel through all those hepatocytes to filter out a lot of those toxins such as ammonia. So then you get buildup of ammonia that then travels into the systemic circulation. And it's really ammonia and molecules and compounds like ammonia, right? The ammonia itself is just one part of this larger equation. It happens to be the part we test, but again, we'll get more into that. But that shunting itself, often driven by liver cirrhosis, is what can cause hepatic encephalopathy. So it most often occurs in patients with cirrhosis, but you can see it in acute liver failure as well, acute on chronic liver failure, large spontaneous portosystemic shunts, and post-tips, which we'll get more into. So at the bedside here, hepatic encephalopathy ranges from very subtle cognitive slowing. Oftentimes people say, this most subtle form of hepatic encephalopathy is sometimes only detected by the patient or by their loved ones. A little alteration in sleep-wake cycle, a little slower or off compared to your baseline, but it can progress to a severe form, which again, we'll talk more about, that can manifest in complete coma, right? Unresponsiveness. So the key concept here is hepatic encephalopathy is not just confusion from cirrhosis. It's a clinical syndrome, and that clinical syndrome often signals some degree of systemic decompensation because most times hepatic encephalopathy is caused by a precipitant. Something has caused the hepatic encephalopathy to start, whether it's infection or bleeding or worsening liver synthetic function, what have you. So the altered mental status is a visible manifestation, but the precipitating event is often the more significant emergency there. So why does this matter? Why are we even talking about hepatic encephalopathy? Well, hepatic encephalopathy is common, but it can be dangerous, especially if it distracts clinicians from the life-threatening triggers, right? It's like DKA or HHS. You always want to know what the precipitant is, because a patient with cirrhosis and confusion may have a lot of different things going on. And you always want to think about, is there a precipitant that is causing hepatic encephalopathy, or is there confusion going on that is actually not hepatic encephalopathy? So anytime you see someone with cirrhosis or liver disease who is confused, you want to think about normal causes of confusion. Are they septic? Do they have GI bleeding, hypovolemia, AKI, electrolyte derangements, hypoglycemia? Do they have a structural lesion in their brain, stroke, hemorrhage? People with cirrhosis are slower to clear some drugs. So is there some buildup of polysubstances that are causing confusion? Is there alcohol withdrawal, SBP, acute liver failure, acute and chronic liver failure, right? So is there a precipitant causing hepatic encephalopathy, or is there confusion that is not hepatic encephalopathy? And this is a difficult question to answer sometimes, right? So we want to stabilize the patient, we want to search for precipitants, we want to treat reversible triggers, and then that'll help guide us in terms of where this patient can be dispositioned, as well as what the next best steps in management are. So to understand this, we always like to go back to kind of the core pathophysiology. And the core pathophysiology with hepatic encephalopathy is something we don't often think as much about. So we talk about ammonia, this ammonia model. And anytime we're talking about hepatic encephalopathy, we're spending time talking about ammonia, right? Did we send in ammonia? Well, what is the ammonia? Okay, well, hepatic encephalopathy is a clinical diagnosis, which we'll talk more about later. But ammonia is kind of central in a lot of these discussions. So let's talk a little bit about it. So ammonia is primarily produced in the gut from protein metabolism, bacterial urease activity, and breakdown of nitrogen-containing compounds. And normally what happens is gut ammonia enters the portal circulation. That then goes through the liver, which detoxifies that blood. You do that through kind of urea and glutamine, and then you excrete that blood into the systemic circulation without ammonia, and then you excrete the ammonia out of the body. Okay, so this step here, this liver detoxification, is what you start to lose in a patient with cirrhosis, right? Because you get all that fibrosis in the liver, all that hepatocyte death, and as such, you can't take that ammonia out, break it down, and excrete it. So in cirrhosis or any portosystemic shunting, right, and that's key. We shouldn't focus too much on cirrhosis, although cirrhosis is far and away the most we're going to the underlying illness that is most commonly associated with hepatic encephalopathy. But any portosystemic shunting, you can see this, right? Anytime blood is not passing through the liver. But in cirrhosis, gut ammonia bypasses the liver because you get impaired hepatic clearance, and that ammonia then just enters the systemic circulation and end up going to the brain. And remember, it's ammonia and other similar compounds, although we always test for ammonia. So in the brain then, the ammonia is taken up by the astrocytes, right? And it's converted into glutamine. And that glutamine accumulation can contribute to astrocyte swelling. This can alter neurotransmission and impair cerebral function. So that is what's actually going on, okay? You cannot detoxify and break down that ammonia in the liver because the liver is fibrosed and you're getting shunting of that blood from the portal circulation to the systemic circulation without effective liver detoxification. That ammonia in the systemic circulation then enters the brain. In the brain, it's taken up by astrocytes. The astrocytes convert it to glutamine, and that glutamine accumulation can cause astrocyte swelling and altered neurotransmission, and this can impair cerebral function. This is why ammonia matters. But ammonia is not the whole story. And that is important to note because ammonia levels can be misleading. Ammonia contributes to hepatic encephalopathy, right? Key there, contributes to hepatic encephalopathy, but ammonia does not perfectly correlate with severity. And this is why you always hear people say that this is a clinical diagnosis. You should send an ammonia level, but the ammonia level does not perfectly correlate with severity. All right, the clinical picture, the degree of confusion is what's going to drive your severity. And that's probably because ammonia is not the only compound or molecule that affects and causes some degree of hepatic encephalopathy or confusion in cirrhosis, but it's the one that we test for most commonly. So important bedside principles here for this ammonia pathophysiologic pathway. A normal ammonia level should make hepatic encephalopathy less likely, but it does not make it impossible, especially mildly. An elevated ammonia level, though, does not prove hepatic encephalopathy. Think clinical, confusion, asteristics, all that stuff that we'll get into. You shouldn't delay treatment while waiting for ammonia if the patient has a really significant clinical exam to suggest hepatic encephalopathy. So don't just treat the number, treat the patient. And then, we always talk about, should you trend ammonia, should you not? In patients who are awake and interactive, trending the clinical exam is much more important than trending ammonia. But in severe ICU cases, especially patients who are intubated on the ventilator, maybe they can't participate in the neurologic exam, sometimes serial ammonia levels can be useful because the diagnosis of hepatic encephalopathy remains clinical. But if the patient can't give you a good clinical exam, the next thing you have is that serial ammonia level, especially if you're trending it. So as always, none of this is intended to be acted upon as medical advice. All this is for educational purposes. Don't act on any of this as if it is medical advice, but from an educational standpoint, there is probably a small indication here to trend ammonia levels in a patient who is critically ill, especially on a ventilator, and can't give you a good clinical exam. All right, there is another kind of pathophysiologic model that contributes to this, and it's called the inflammation model, and this is why people think a patient with stable cirrhosis can suddenly become obtunded with hepatic encephalopathy, and it is all about that precipitating factor, right? So someone with cirrhosis, let's say they're on lactulose at home, they've kind of reached a neutral status where they do not have hepatic encephalopathy, but then something happens and they develop hepatic encephalopathy. And that might be from infection, systemic inflammation, GI bleeding, renal failure, electrolyte derangements. All those things seem to amplify the neurotoxic effects of ammonia. And like some people say, ammonia loads the gun, inflammation pulls the trigger. Why exactly this happens is very complex and not totally clear. But this is that relationship between ammonia and then precipitating factors, right? Because when you have cirrhosis, you are not as effective at detoxifying that ammonia from the portal circulation. But usually there's a precipitant that then tips you over the edge, and that precipitant usually causes inflammation, and that inflammation drives worsening of that neurotoxic effect of ammonia through variable pathways. Okay, let's get into classifications. How do we classify hepatic encephalopathy? Well, there's West Haven grading that we'll talk about, but first just to kind of introduce the different degrees of classification, right? So there's like kind of minimal or mild, and this is, as we said, very subtle cognitive dysfunction, slowed reaction time, some sleep-wake disturbance, not able to concentrate, impaired driving ability, and this is really tough to identify. We often, counsel people in the clinical arena that family and the patient are sometimes the best one to notice this, that they just seem a little bit off. But if you're interviewing the patient, you might not even really pick up on this because you don't know the patient well. And then there's more obvious, there's overt hepatic encephalopathy. This is clinically apparent. Patients are confused, disoriented. They have asteristics, which is that flapping hand tremor. You have them hold their arms out in front of them, put their palms upwards, and then you'll see that flapping tremor. That's asteristics. And then there's somnolence, coma, at its most severe. So this is the more kind of prevalent type of hepatic encephalopathy that we will see in emergency critical care medicine because it's more clinically apparent. And the way we grade these is called the West Haven grading criteria, and it's grades 1 through 4. And we're simple people with simple brains. The way we think about it is grade 1 is that very mild form: attention deficit, sleep disturbances, irritability, and subtle confusion. And then the way we remember it is then we remember grade 4 is a coma, right? So grade 1 is mild, you can barely tell. Grade 4 is a coma, and then you fill in grade 2 and 3 in your brain. So grade 2 is a little more clinically apparent. There's some lethargy or tiredness, some disorientation, personality changes, inappropriate behavior. And you start to see that asteristics. And grade 3 is obviously going to be a progression towards that coma, that grade 4. So grade 3, you're more somnolent, you're markedly confused, but you are arousable. So it's this progression, right? From grade 1 to 2 to 3 to 4. Grade 1 being mild and really difficult to even clinically identify. Grade 2's able to be clinically identified. The patient's a little more confused, disoriented. They start to have asteristics. Grade 3, you're on your way to grade 4, that coma. So you're really confused, you're lethargic, but you're arousable because you're not in that grade 4 coma yet, and grade 4 is that coma. So grade 3 and 4 are really significant, right? These patients need close monitoring, depending on how severe it is. There can be airway compromise, there could be concern for cerebral edema, all that kind of stuff. So we'll talk about that. So initial approach in the ED or ICU, as with anything, we start with the basics. This is straightforward stuff: airway, breathing, circulation. Get a glucose, they're confused, get a temperature, and do a focused neurologic exam, right? It's important that we always think about hepatic encephalopathy, but that we don't anchor on it, right? These patients can get altered mental status, they can get encephalopathy from the same reasons that someone without cirrhosis gets hepatic encephalopathy. They're hypoxemic, they're hypercapnic, they're in shock, not perfusing their brain, they're septic, there's trauma, there's an intracranial catastrophe, medication effects, hypoglycemia. So think about those causes of altered mental status, and then after that, you can think more about hepatic encephalopathy, but don't assume every confused patient with cirrhosis, quote unquote, it just has hepatic encephalopathy, right? Think about those, that differential for altered mental status in general, using whatever mnemonic or kind of trick you use in your brain to remember those things. So the most important management step after you have identified hepatic encephalopathy is find the precipitant. This is just like DKA or HHS. Find the precipitant. What caused this patient to go into hepatic encephalopathy? Because until you fix that precipitant, you're not going to be able to fix the hepatic encephalopathy. And, a lot of times, we shouldn't say a lot, but medication non-compliance is something that we often talk about, right? The medications for hepatic encephalopathy, lactulose, rifaximin, these things cause diarrhea. Patients understandably don't like them. So medication non-compliance is something we often talk about, but do not anchor on that because you will miss something. Common precipitants, look how long this list is. If you're listening to the podcast form, you probably don't need to hop over to the video just to look at this list. We'll read it quick. But there's a long list, and this isn't even exhaustive, of common precipitants: infection, GI bleeding, dehydration, AKI, electrolyte derangements, sedatives, benzos, alcohol withdrawal, large protein loads, TIPS, portal vein thrombosis, medication non-adherence, progression of liver disease, right? All of these things can be precipitants for hepatic encephalopathy. So you need a very structured approach to evaluate these patients. And in our head, did we spell it out later on? Not really. We'll get into the labs and all that, but in our head, the big three that we always think about right off the bat is GI bleeding, right? In a cirrhotic, is that a variceal bleed? GI bleeding, infection, right? So these patients need a workup for GI bleeding, CBC coags, looking at their stool, all that kind of stuff. They need a workup for infection, even if they're not showing definitive signs of an infection. And then kind of AKI and electrolyte derangements we batch together. These are the three we always think about. And then the fourth one, progression of liver disease, right? Is there kind of an acute on chronic liver injury? And with that, we often batch in portal vein thrombosis because that can cause a progression of liver disease. So these are the ones we often think about: GI bleeding, infection, AKI, electrolyte derangements, progression of liver disease, but ischemia, right? All these things can cause it. So figure out your mental model, just have a structured approach, and not to say you have to like blindly work all these things up, but you certainly have to think about it and get a history and physical that help you understand the pretest probability for it. All right, so initial diagnostic workup we kind of touched on. These are pretty big workups, right, because of all those precipitating factors. Some of it's straightforward. You want a glucose, you want a complete blood count, a complete metabolic panel, mag, phos, coags. If indicated, right, low threshold to get a blood gas. Make sure they're not hypoxemic, acidemic, hypercapnic. We're going to take a drink of our coffee. If they look sick, lactate, right? Because sepsis is one we got to really ponder deeply. Blood cultures, urinalysis are two tests that in patients with cirrhosis, right, they're relatively immunocompromised. So they might not show the same signs of infection that someone who is immunocompetent would show. So not to say you have to get a UA and blood cultures on every hepatic encephalopathy, but gosh, pretty close, right? Especially for those grade 3 and grade 4 hepatic encephalopathies who can't give you a dependable history, very low threshold to get that infectious workup. Ammonia level, ideally collected. We personally feel like you should get an ammonia level, even though your clinical exam should more drive you. Tox, alcohol level, Tylenol level, salicylate levels, all that tox stuff can be important too, because those can be precipitants. So these can be pretty big workups. Imaging, CT head. This is something debated, right? If someone has known cirrhosis, they have kind of recurrent hepatic encephalopathy. It's grade 1, maybe not severe grade 2. It's mild. They've gotten a bunch of CT heads. You maybe don't have to CT head every single patient, but you should really consider it if it's their first episode, there's any signs of trauma or fall, any neurologic deficits, headache, they're on anticoagulation, their mental status is depressed, the diagnosis is unclear, they're not improving as expected. Because cirrhotic patients are at increased risk for a lot of intracranial catastrophes, right? Increased risk for bleeding, falls, infection, metabolic derangements, medication toxicity. So CT head for these patients, we personally have a low threshold to get a CT head. Especially because of where we work, but you probably don't need to get a CT head in every single one of these patients, especially if they're grade 1 or mild grade 2, and you have a good etiology, a good explanation, and they're getting better. But cirrhotic patients are high risk for complications that can enter into the cranium, like bleeds and strokes and infections, cerebral edema, all that kind of stuff. So just be thoughtful, especially in your sicker hepatic encephalopathy patients, because many of them probably should have a CT head. All right, quick paracentesis shout out. This is probably misplaced because we're not talking about spontaneous bacterial peritonitis right now, but of note, all patients admitted with cirrhosis and ascites should generally receive a diagnostic paracentesis. SBP, spontaneous bacterial peritonitis, is a huge cause of hepatic encephalopathy. So this can be a nidus for hepatic encephalopathy, even without the classical findings of SBP, abdominal pain, fever, peritoneal signs. And that's why the recommendation is that these patients admitted with ascites get a paracentesis, even if it doesn't seem like they have SBP. All right, let's talk about a little bit of our therapeutic strategies here. The first line, the workhorse, is lactulose. So lactulose is the foundation of treatment for overt hepatic encephalopathy. And what lactulose does, right? Lactulose, people sometimes take it for constipation, but it does a couple of things that we don't always talk about. The first of those things is it actually acidifies the colonic contents. This helps convert ammonia to ammonium. It reduces ammonia absorption. It also acts like a cathartic, right? We poop more, and then we get decreased nitrogenous substrate in the gut. So all of these things help decrease our ammonia levels in the blood to help offload to the liver, since that liver is not able to detoxify that ammonia. So the goal here, just to be upfront about it, is you don't want just kind of maximum diarrhea. You don't want the patient just, losing electrolytes and getting dehydrated because they're just having stools nonstop. You want kind of this controlled catharsis. And the way we do that, and again, all dosing here, this is all just educational, none of it's intended to be acted upon as medical advice, but you can give either oral, PO, or rectal, per rectum, PR. Lactulose. The oral or enteral lactulose, people do it differently, so take this as kind of just a structure, but choose your own journey here. Some people will do 20 to 30 grams of lactulose Q2 hours until bowel movement, and then titrate. Be careful with this, right? You don't want the patient getting that much Q2 hours forever. And if they're not pooping after a couple doses, you should be like, well, why aren't they pooping? Do they have an ileus or bowel obstruction? Because giving lactulose in those populations can actually be very dangerous. It can cause bowel ischemia. So be thoughtful and monitor if you do choose to take this approach. But this is one approach from an educational standpoint that could be considered. After a bowel movement comes, you want to titrate to about 2 to 3 or 3 to 4 soft bowel movements per day. That's kind of the happy place. And remember, the number of bowel movements is somewhat related to how they're doing. If you titrated to 1 to 2 bowel movements and they're still confused, and then you titrate to 3 to 4 bowel movements and they're still confused, and it is hepatic encephalopathy and you're not missing a precipitant or anything like that, 3 to 4 bowel movements. But if you're having 4 good bowel movements, the patient is still confused with hepatic encephalopathy, think about, what are you missing? Did you miss a precipitant cause? Or is this not all hepatic encephalopathy? Because that should really be helping them. If patients are unable to tolerate PO or enteral therapy, rectal lactulose can be used. This is a retention enema, which can be tough because the patient theoretically needs to hold on to it, retain it for it to work. And patients who are severely ill and can't tolerate oral lactulose sometimes have trouble doing that, but you should try it, right? This is something that can be done. So lactulose pitfalls. Essentially, it's like avoid overdosing and avoid underdosing, right? If you underdose, the hepatic encephalopathy might get worse or not better. If you overdose, you might have way too much stool, get dehydrated, get electrolyte derangements, and that can then worsen hepatic encephalopathy. Excessive lactulose can cause dehydration, hypernatremia, hypokalemia, aspiration risk, worsening renal function, all that kind of stuff. So just be very thoughtful. You want to walk that line, trying to make sure that porridge is not too hot or too cold, but just right. So be thoughtful, monitor stool output. Don't just set it and forget it, especially in sick hepatic encephalopathy. These should be patients we're keeping a close eye on and titrating their lactulose in real time based on how they're responding to it. All right, another therapy we can give is rifaximin. This is one you guys have probably heard about. Rifaximin is a non-absorbable antibiotic. This reduces intestinal ammonia-producing bacteria. So unlike lactulose, which helps you absorb less ammonia and excrete more ammonia, rifaximin is actually an antibiotic that just kills ammonia-producing bacteria. And with less ammonia-producing bacteria, you obviously will produce less ammonia. And if there's less ammonia in your gut, you will absorb less ammonia. This is commonly an add-on therapy to lactulose. Depending, it can be expensive, and not all insurances will approve it except for certain indications. Many of them are recurrent hepatic encephalopathy prevention, hospitalized patients with significant hepatic encephalopathy, or when response to lactulose is inadequate. And educational purposes dosing, 550 milligrams twice a day is something that's commonly used. So your sick patients with hepatic encephalopathy in the hospital who are getting lactulose probably should also be on rifaximin, although just know that there is some complexity to this, especially from an outpatient insurance approval standpoint. Rifaximin is not usually the immediate life-saving move. It's kind of an important part of inpatient management and secondary prevention, but lactulose is the workhorse here, not rifaximin. So lactulose versus rifaximin alone. Lactulose remains the initial first-line agent. Rifaximin is usually added on rather than used solo, especially in patients with recurrent or incomplete response. So just to dive a little bit into the precipitants, just because this is such an important thing, right? Anytime you're diagnosing hepatic encephalopathy, your next question is, what is the precipitant? And we just wanted to make it a little more detail-oriented. So some of the big precipitants here that we talked about, you should always think about infection. Most common sources are SBP, spontaneous bacterial peritonitis. These patients should be getting a para if they have ascites, independent of whether you think they have symptoms of infection or not. UTI, pneumonia, bacteremia, cellulitis, cholangitis. Do not wait for a fever. Patients with cirrhosis may not have a robust infectious response even when they have serious infection, because cirrhosis in itself, as we have said, is a relative immunocompromising state. Okay, so these patients are not going to mount the same response to infection that someone without cirrhosis would. So if they're sick, really a broad infectious workup can be important, even if they don't have those localizing symptoms we usually look for. All right, GI bleeding. Another big one, right? GI bleeding worsens hepatic encephalopathy because you get hypovolemic, you lose hemoglobin. You also get more of a nitrogen load from digested blood, which can increase ammonia production. And this is, again, one of the really important precipitants to recognize early, right? Get that complete blood count, look at the stool for any signs of bleeding or blood, talk to the family about if there's been any bleeding or blood in their stool recently. This is one of those critical ones that you shouldn't just overlook or bypass or skip by. Constipation is another one. This is one that you might see, but maybe is not as common. But if you think about it, it makes sense, right? If you're constipated, the increased intestinal ammonia production and absorption happens because you're not having bowel movements to excrete that colonic and intestinal ammonia. So make sure the patient does not have an ileus, make sure they're not obstructed, and then get to them pooping. But just know these patients are often very ileus prone, especially who are sick. So just be cognizant of that and be thoughtful. A patient with hepatic encephalopathy with an ileus can be a really tough thing to navigate and manage. So keep an eye on that. And if you're just giving someone lactulose, do serial abdominal exams, make sure they're not getting more distended, make sure they don't have any more worsening intestinal dilation or abdominal pain or vomiting or any of that jazz. And if they do, think about ileus, think about constipation. Electrolyte abnormalities is a big one. Luckily, we often detect these early because many of us will send a complete metabolic panel right off the bat upon presentation to the emergency department. But hypokalemia specifically can worsen hepatic encephalopathy by increasing renal ammonia production. And then hyponatremia can worsen cerebral dysfunction, which then can kind of compound the hepatic encephalopathy. A lot of our cirrhotic patients, right, are on some degree of diuresis. This is usually something like furosemide combined with spironolactone. And this is just to try to decrease ascites, pleural effusions, all that kind of stuff. But over-diuresis can certainly then lead to electrolyte derangements, kidney dysfunction, all that kind of stuff, which can prompt hepatic encephalopathy. As we mentioned, acute kidney injury is another one. Acute kidney injury worsens hepatic encephalopathy by reducing ammonia clearance and increasing systemic inflammation. AKI should always be taken serious, right? Many of these acute kidney injuries are from things like hypovolemia infection, nephrotoxins, but you can also get hepatorenal syndrome, which we'll probably talk about on the channel at some point. Let us know. That might be a good topic for us to cover. But AKI in cirrhotics can be very complex and challenging, so be thoughtful, be aggressive in diagnosing it, and that can be one of the precipitants of hepatic encephalopathy. Sedative medications, don't need to read all of them, but these patients are often complex and may have history of substance use and all that kind of stuff. So any sedative and medications can prompt hepatic encephalopathy as well, including things like alcohol withdrawal and seizures and all that jazz. All right, we wanted to shout nutrition out a little bit. This has evolved. There was an old kind of school teaching that emphasized protein restriction in these patients, but the modern approach, now that we have more evidence, is different, right? Patients with cirrhosis are often sarcopenic, and skeletal muscle helps actually metabolize ammonia. So prolonged protein restriction can worsen malnutrition and may worsen long-term outcomes. So we no longer emphasize protein restriction. These patients need to build up muscle and need protein to do that. But we would say in general, there are some nutritional things that we should be thoughtful of. Prolonged fasting can worsen hepatic encephalopathy. These patients need adequate calories, so do not reflexively restrict protein. Enteral nutrition is important. And then dietitian involvement and all that's good. And, if you have a patient, and this is not in our purview, this would be more kind of outpatient or inpatient non-ICU management, but recurrent hepatic encephalopathy, you've done everything you can for that patient. There's still some times where folks will consider kind of different protein sources, vegetable or dairy, as a way to try to decrease the recurrence of hepatic encephalopathy. That is kind of beyond our level of understanding, so we will defer to the folks who do that to explain it more. But in general, protein restriction is no longer emphasized in the management of these patients. So for critically ill patients, nutrition is part of ammonia management because muscle is an accessory ammonia detoxifying organ, and we need these patients to build up as much muscle as they can because they're often sarcopenic. All right, getting into even the more severe stuff, right? And this is getting into severe refractory hepatic encephalopathy and some of the more advanced therapeutic measures we can consider. And remember, if this is getting longer confusing, this PDF, the study guide, is on our Patreon page and our Patreon community, linked in the episode description. If you want to print it out and annotate it just like we are. So totally consider checking that out if you want. Okay, so severe refractory hepatic encephalopathy. So ICU admission can be considered for all sorts of patients with hepatic encephalopathy, but certainly grade 3, grade 4 when this starts getting severe. Remember, we said grade 4 is essentially coma, and grade 3 is on the precipice. You know, grade 3 is stuporous, lethargic, but arousable. So these are really sick patients. Airway protection is a big consideration. Many of them, especially with grade 4, will need intubation. And sometimes that intubation is just for a day or two till they get better, but many of them need intubation for airway protection. In addition to that, as we said, these patients often have a precipitating factor. It's not usually just hepatic encephalopathy. Many of them are in shock or septic or have GI bleeding or renal failure, all that kind of stuff, acute on chronic liver failure. So the hepatic encephalopathy itself can require ICU admission for mental status, but the precipitating factors mixed with the hepatic encephalopathy can often be a reason for ICU admission as well. So if a patient is not improving, if they have refractory hepatic encephalopathy, you really need to reassess that patient. This is critical, right? Don't just keep dragging feet over and over and over and be like, oh, maybe they'll be better the next day, maybe they'll be better the next day, right? These are really sick, really complex, really high mortality patients. So always think, is my diagnosis correct? Is this hepatic encephalopathy? Am I missing a precipitating factor, occult infection, GI bleeding, constipation or ileus, right? Is there renal failure? Is there a sedative or toxin on board? Did the patient recently undergo a TIPS? Is my lactulose reaching the gut? Right? Is this actually acute liver failure? Do not simply keep escalating lactulose without reassessing the underlying problem. And the underlying problem reassessment in general is, do I have the right diagnosis? Right? Is the diagnosis correct? And, or do I have a untreated precipitating factor? Those would be the two kind of larger categories that you should always reassess for, because if you have either of these things wrong, your hepatic encephalopathy probably will not get better. All right, what's the role of renal replacement therapy for these patients? Well, in general, renal replacement therapy is not routine for just standard cirrhosis-related hepatic encephalopathy, but in severe critical illness, it may be considered, right? You might have refractory hepatic encephalopathy, marked hyperammonemia with coma, cerebral edema, or just acute renal failure, volume overload, severe acidosis, all that kind of stuff, because CRT actually helps with ammonia clearance. And this is kind of best established conceptually with acute liver failure and severe hyperammonemia, but you can do it for cirrhosis-induced hepatic encephalopathy as well. But this is reserved for severe cases, right? When you have grade 4 hepatic encephalopathy, you're worried about cerebral edema, or you have hepatic encephalopathy with another indication for dialysis, certainly would be true too. But dialysis will help filter out ammonia and improve ammonia clearance. And this is kind of the tool in our back pocket that we can do to treat these patients when they have severe disease. All right, let's talk about cerebral edema. This is the kind of feared complication of hepatic encephalopathy, right? We said that ammonia gets taken up by the astrocytes. The astrocytes convert it to glutamate, and that can cause swelling amongst other things. So you can get cerebral edema, and that's the feared complication. Now, this is a little different in acute liver failure versus cirrhosis. In cirrhosis, the brain's often adapted to some degree of chronically elevated ammonia levels. So clinically significant cerebral edema in cirrhotic patients is much less common. It can still happen, but it's much less common. In acute liver failure, though, ammonia often rises rapidly, and cerebral edema happens much more rapidly morbidity and is a major cause of death in these patients, right? So in cirrhosis-related hepatic encephalopathy, you usually, not always, but usually have a little bit of time, right? Precipitant control, lactulose rifaximin, aggressive supportive care. But in acute liver failure with hepatic encephalopathy, you really have to have a low threshold to involve your neurocritical care folks, cerebral edema prevention, and really transplant center involvement in these patients, because the hepatic encephalopathy, the brain is not adapted to those higher ammonia levels, and as such, that acute rise in ammonia and acute liver failure can be deadly in terms of cerebral edema. Okay, post-TIPS hepatic encephalopathy, this is a big point of discussion as well. TIPS, we actually put out a dedicated episode on TIPS, so depending on when you watch this, just search Whiteboard Medicine TIPS and you'll probably get a whole deep dive on it. But TIPS is a procedure that essentially puts a shunt between the portal and systemic circulation, right? So we have a liver, we have our portal circulation, we'll draw it over here, we have our systemic circulation, blood flows through the portal system into the fibrosed liver. It makes it harder to flow through, so we get increased portal pressures, and then eventually that blood dumps out into the systemic circulation. A TIPS, a portosystemic shunt, essentially puts a shunt between the portal system and the systemic system, so that blood can actually then bypass the liver. It can just go through the shunt, and that'll then decrease portal pressures, but less blood is then going through the liver, so you get even less detoxification, even less ammonia clearance after a TIPS, which can precipitate or worsen hepatic encephalopathy by increasing portosystemic shunting, because that's literally what a TIPS is meant to do. It is meant to increase portosystemic shunting. Risk factors for those who are higher likelihood to have severe hepatic encephalopathy after TIPS: older age, prior hepatic encephalopathy, advanced liver disease, if the shunt you place has a large shunt diameter, if you don't have enough muscle, remember muscle helps break down ammonia, or if you have any renal dysfunction. This can be really, really significant and important. Now, TIPS can be life-saving for patients. TIPS can be definitely indicated, but this is one of the feared complications that can happen. All right, we're getting close to the end here. We got some common pitfalls that we're going to talk about, some high-yield pearls, and then we will get into our multiple-choice questions, and that'll be that. So starting with common pitfalls, these are going to be things that we talked about throughout the episode, but that we just wanted to drive home because we felt they were important. One is anchoring on hepatic encephalopathy too early, right? Not every confused cirrhotic patient has hepatic encephalopathy. Always consider other causes, right? Pearl number 2, treating ammonia the number instead of the patient, right? An elevated ammonia supports the diagnosis but does not replace clinical reasoning. Do not discharge a confused patient just because the ammonia is improved. Do not admit a completely normal patient only because the ammonia is mildly elevated. Obviously not medical advice, just education. All right, pitfall number 3 is forgetting the rectal route of lactulose administration, right? If the patient cannot swallow safely, maybe they're too confused, maybe they're vomiting, lactulose can be given through a rectal tube, right? It can be given rectally, and you should be doing that to try to clear up the hepatic encephalopathy and then get the patient to tolerate oral lactulose. And then common pitfall number 4 is causing dehydration with lactulose. This is that overdosing, right? You want to shoot for 2 to 3 or 3 to 4 soft bowel movements daily, not just uncontrolled profound diarrhea, because overtreatment can cause electrolyte derangements, can cause dehydration, it can cause worsening renal function, and all of those things can actually be precipitants to then cause hepatic encephalopathy. All right, and then common pitfall number 5. We're almost done with pitfalls. I think there's 6 total. Missing spontaneous bacterial peritonitis. This is so critical, right? We get it. Doing paracentesis is not everybody's favorite activity, but if a patient has ascites and hepatic encephalopathy, they need a paracentesis. It doesn't matter if they're not febrile. It doesn't matter if they don't have a white count. They need a paracentesis because SBP is one of those big-time precipitating factors that can lead to hepatic encephalopathy, even without definitive clinical signs of spontaneous bacterial peritonitis. And then 6, missing acute liver failure, acute on chronic liver failure, right? So hepatic encephalopathy plus acute hepatic injury and INR elevation should trigger concern for acute liver failure. And remember, hepatic encephalopathy and acute liver failure is much more kind of deadly from a cerebral edema standpoint because the brain has not had time to kind of acclimate to that elevated ammonia. All right, some high-yield pearls, then we'll get into practice questions, and that'll be that. These high-yield pearls we'll read quickly, but pause here if you want to take more time. Hepatic encephalopathy is a diagnosis of exclusion in the emergency department. The precipitant is often more dangerous than the encephalopathy itself, other than an acute liver failure. Lactulose is first line, but make sure you're not causing uncontrolled diarrhea. Rifaximin is a second-line therapy. It does not really have any rescue therapy properties. A normal ammonia makes hepatic encephalopathy less likely, but remember, hepatic encephalopathy is a clinical diagnosis. Always check glucose, always consider infection, always consider GI bleeding, always consider SBP. All admitted patients with cirrhosis and ascites should get a paracentesis. Grade 3 and grade 4 hepatic encephalopathy really should prompt consideration for ICU admission. And then hepatic encephalopathy and acute liver failure is different than hepatic encephalopathy and chronic cirrhosis, and is much more worrisome. Although hepatic encephalopathy and cirrhosis is obviously worrisome as well, but acute is even worse than chronic. All right, last but not least, we have 3 practice questions to see if we learned anything. The way we do these practice questions, if you have not done them with us before, is we read the question, read the answer options, then we dive right into the answer. So if you need more time to think about the answer, just pause the episode. We also have a bunch of multiple choice practice tests within our Patreon community if you're kind of like this style. So definitely check those out if you're interested. Question 1. A 58-year-old patient with known cirrhosis presents with confusion and asteristics. He is afebrile, mildly tachycardic, and has moderate ascites. Which of the following is the most appropriate emergency critical care principle related to this? A. Give lactulose and defer further evaluation unless the ammonia is elevated. B. Treat presumed hepatic encephalopathy while actively searching for precipitating cause. C. Avoid paracentesis unless the patient has abdominal pain. Or D. Correct the INR before giving lactulose. Pause if you need to. The correct answer is B. Right? Treat hepatic encephalopathy while actively searching for the precipitating cause. This is critical, right? Clinically, this patient has hepatic encephalopathy. They're confused, they have asteristics. And then the question is, what's the precipitating cause? Because that should always be the question you ask after you diagnose hepatic encephalopathy. All right, question 2. Which of the following is the best target when titrating lactulose for overt hepatic encephalopathy? A. Complete cessation of bowel movements. B. 1 bowel movement per week. C. 2 to 3 soft bowel movements per day. Or D. Continuous watery diarrhea until ammonia normalizes. Pause if you need to. Hopefully you don't need to. Correct answer is C, right? You're titrating lactulose to 2 to 3 or 3 to 4 soft bowel movements per day. Remember, underdosing or overdosing can shoot you in the foot and make hepatic encephalopathy worse. Underdosing because you're not having effective ammonia clearance, and overdosing because you can cause electrolyte derangements, dehydration, AKI, that can actually precipitate worsening hepatic encephalopathy. All right, last question but not least. A 42-year-old patient with no known liver disease presents with acute confusion, AST of 4,500, ALT of 5,200, INR 3.2, and progressive somnolence. Which statement is most appropriate? A. This is typical chronic hepatic encephalopathy and can be managed with outpatient lactulose. B. Hepatic encephalopathy cannot occur unless cirrhosis is already known. C. This presentation should raise concern for acute liver failure and urgent transplant center consultation. Or D. Rifaximin alone is definitive therapy. Pause if you need to. The correct answer is C. This presentation should raise concern for acute liver failure and urgent transplant center consultation. So that is all we have for you today. Let us know what thoughts, comments, questions you have down below. We have a little video on our Patreon community at the end of this if you want to kind of check out what is offered on there in video form. Stick around. Otherwise, though, we appreciate y'all. Stay well. Keep learning. If I could borrow a quick 60 seconds of your time, I wanted to introduce you to a community we're really excited about building. And that is our Patreon community. In this community, you will get access to high-yield medical education posts, ad-free videos, study guides, practice questions, mini courses, book chapters, and much more. You will see that by joining this community, you will get access to the PDFs, the study guides for every single YouTube video. Here's an example of one of those right now. In addition to that, you will get access to mini courses. In these courses, we will have videos, study guides, practice questions, bedside tips and tricks, and 30 practice questions at the end to test your knowledge. In addition to that, we have collections on every major emergency critical care topic that contains videos, medical education posts, practice questions, study guides, all categorized. And lastly, we have book chapters. These book chapters are high-yield clinical reviews, such as this one on the basics of mechanical ventilation. Beyond that, we have ad-free videos, we have practice questions, and we are constantly innovating and integrating new resources for you all. If you have a passion for emergency critical care medicine like us, consider joining this community today. In it, we hope that you will find all the resources necessary to push your knowledge to the next level and really improve the bedside care of these critically ill patients.